To our Zoom participants, can one of you raise your hand virtually if you can hear me? Thank you. And I don't see Isabel Cisco yet. Isabel, are you there? But maybe name something differently on your Zoom description. Yes, we're getting closer. Okay, everyone, just so you know, we are live streaming on YouTube. And bear with us as we sometimes may need to go to our virtual software here and make sure everything is operating. Dusty, you want me to pull up the agenda or go ahead and wait a second? Okay. Okay, I think Dusty, everything's running here. You want to do a volume check on you?
We have a low battery. We sure do, yep.
Stand by, we're going to replace a battery here. I've got some too.
Of course, it's funny if you started doing it. I did, yes. And I gave them back to you, I hope. Okay, good. You don't have any batteries. Oh, for now. Okay. Great. One question I didn't see who was on our panel is I don't know. It was very yeah.
Okay, if you're just joining us virtually, we will be starting in just a moment.
Okay. I just.
Yep. We might want to pump you up.
Good afternoon. This is just a mic check.
I'm gonna bring you up, okay?
Okay. Great testing. Can you hear me? Yeah. Good afternoon. Yes. Yeah. Okay.
Good afternoon, everybody, and welcome to this Lincoln County Overdose Symposium. I'm Claire Hall, Chair of the County Board of Commissioners, and I appreciate all of you being here today. Opioid abuse is a crisis that's been growing for decades, and the results are increasingly tragic. For many years, opioid deaths nationwide were numbered in the tens of thousands. Unfortunately, the COVID-19 pandemic escalated the overdose crisis to new levels. The Centers for Disease Control reported that in the 12-month period ending in April of 2021, all overdose deaths in this country surpassed 100,000 for the first time in history. Yet in many ways, the landscape looks bleak. But with courage, imagination, and some new resources, we really can make a difference. In 2020, Oregon voters approved Measure 110, which promised new resources for prevention and treatment. Opioid manufacturers are beginning to be held accountable in the courts, paying tens of millions of dollars in damages for the destruction they've been complicit in. In March, the state of Oregon received a $426 million settlement. However, a recent federal court ruling may put future agreements like this in jeopardy. Resources alone, however, are not enough if we don't use them wisely and well. One thing is abundantly clear: no single approach will be enough. We need a variety of options. Certainly, law enforcement has a critical role in containing the manufacture and distribution of illegal drugs. Law enforcement, though, is not alone the answer. I've had veteran law enforcement officers tell me they're tired of arresting the children of people they took into custody as rookies. State governments are finding that mass incarceration for drug crimes is proving to be ruinously expensive while not making communities safer. As a result, states, including Oregon, are curbing the growth of their prison systems and investing in more alternative approaches. A comprehensive approach absolutely has to start with prevention. A report a few years ago said public entities are only spending $1 on prevention for each $57 that they spend shoveling up the wreckage of addiction. That's a phrase that's really stayed with me, and I hope will stay with you too. Shoveling up the wreckage of addiction. When we realize we are talking about human lives, it further emphasizes the horrible toll overdoses are taking everywhere in this land. Treatment, consumer-centered treatment that centers on the whole patient and which includes wraparound support services, must be at the center of our efforts as long as this crisis continues to wreak havoc. The challenges are great, but but so are the opportunities. May we all work together to find a path toward greater healing for our communities, our families, and our neighbors who struggle under the yoke of addiction. This is really a great turnout here today, and I'd just like to acknowledge a few of the people who are with us for this afternoon. And thanks to everybody who made the time commitment to be here today, but I would like to acknowledge the Honorable Cheryl Bockhart, Lincoln County Presiding Judge. Mayor Rod Cross of Toledo. Our district attorney, Laney Danforth. Representative David Gomberg. My colleagues on the County Board of Commissioners, Doug Hunt and Katie Jacobson. Different tables, don't have a meeting going on. Tim Johnson, our county administrator. Sheriff Curtis Landers. And Mayor Susan Walke of Toledo. I mean, of Lincoln City. I know better. Uh-oh. I'm not going to live that one down for a while. Maybe ever. Logistics. In case anybody hasn't found the restrooms yet, they are right across the hall. And if you haven't had a chance to sample the goodies, there are sandwiches, chips, drinks, cookies, coffee. So don't be shy about helping yourself at any time today. I want to give credit to the people who have made this amazing event happen. The Symposium Planning Committee, all from Health and Human Services, Asia Richardson, Health Education Specialist, Callie Lamondola Gilliam, Communicable Disease and Health Promotion Manager, Jennifer Beckner, Substance Use Disorder Prevention Grant Coordinator, Florence Portal, Public Health Director, and Jane Romero, our Health and Human Services Director.
Claire,
Yes.
one more mayor.
Oh, who did I miss? Oh, yeah, that guy. Dean Sawyer, who I've only known for like about 33 years. He just kind of blends into the woodwork. He is such an essential part of the scenery. Well, Dean, now I've got two boo-boos that I'll never live down, but thank you. Well, you're almost rid of me, and we'll have the opportunity to hear from the experts and professionals. So I'm going to finish up by introducing our facilitator, Dusty Linnell. Dusty serves the communities of Lincoln and Tillamook counties with the Oregon State University Extension Family and Community Health Program, which is affiliated with the College of Public Health and Human Services. She works in coastal communities to advance health through education and applied research. In addition, she often serves as a facilitator, supporting groups as they seek to understand and make decisions about complex issues affecting the health of community members on the Oregon coast. So let's give Dusty a warm welcome now.
Good afternoon. Can you all hear me okay? Right. So we have two goals for today. One is to develop a deeper understanding of the issues of overdoses in Lincoln County. And we're going to get to do that with a review of data. Our second goal for today is to develop a deeper understanding of the comprehensive work that you all are doing to address these issues across the county. We have our agenda here, which you also have copies of on your table. So we're going to start off with a data review. We are going to have a really great panel of presenters to talk about a variety of programs and services happening across the county. And we are going to follow that with some participation by you all to invite you to tell us what else is going on. We'll follow that by another section focused on what's being planned for the future. So I'm really excited that you're here with us today. We have a lot to get through. One of the things that I want to note is that we did not schedule a break in our agenda, so we can make sure and get to all this great stuff. So please get up as you need to, take breaks whenever you need. I also wanted to say that there's somebody who left some keys on the sign-in table. So if that's you, they're right out there on the sign-in table. Let's see. All right. The last thing that I've been asked to share before we get started is that there's a table on the wall. There's 2 of them actually that have great brochures and posters. Be sure to check that out before you leave. All right. So with that, what we're going to do is we're going to jump right into our overview of data. I'd like to introduce Jennifer Beckner, and she is with the Lincoln County Health and Human Services. She's the Overdose Prevention Coordinator and Substance Use Disorder Prevention Grant Coordinator. Jennifer. Ooh, I touched something.
Good afternoon. I'm so excited to see so many of you here today. This has been a dream of mine to get recognition for this problem. This has been something that we've been anticipating coming to the West Coast for a couple of years now. We were having a lot of overdoses on the East Coast, and for a while, people out on the West Coast were saying, oh, it's never going to hit us. Fentanyl is never going to get here. And the reason for that is people here prefer black tar heroin, and on the East Coast, they use white angel dust heroin. And so they thought that we'd never see fentanyl mixed in with our heroin or any of our other drug supplies, and we were wrong. It's here, and we're seeing a lot of fatal and non-fatal overdoses. And as Commissioner Hall stated, there has definitely been an increase with COVID. We're seeing a lot of people who have long-term recovery that have relapsed. And as our law enforcement all knows, most of the drugs, illicit drugs out on the street right now are laced with fentanyl. So we're going to talk about what we do know, what we don't know, and what we're currently doing to work on this problem. And as Commissioner Hall stated, we will be looking at receiving opioid settlement money. Unfortunately, only cities with 10,000, a population of 10,000 and higher are going to be receiving this money. So for Lincoln County, that means Newport and Lincoln County itself.
Lincoln City.
Oh, and Lincoln City. So this is some national data, and as you can see, it's primarily fentanyl that's involved in all of the deaths that are occurring. And so for Oregon data, we are second for the percent of population with past year substance use disorder for teens and adults. And what's is that we are also ranked 50th in accessible treatment. And so while we have a very high need for treatment, we really don't have a lot of options available for people right now. As you can see, we're seeing the prescription opioid overdose deaths come down a little bit. And one of the reasons for that in the state of Oregon is that the overdose prevention coordinators were tasked with, of course, to work with physicians and community health clinics to help people get signed up for something called the Prescription Drug Monitoring Program, or the PDMP. And that's something that pharmacists and doctors can check to see if somebody's already maybe doctor shopping and getting opioid prescriptions from many different sources. It also assists pharmacists in maybe putting up a red flag if a patient has a prescription for a benzodiazepine and an opioid, and a benzodiazepine is something like Ativan or something that a doctor would prescribe for anxiety or for sleep. This is the drug overdose death rate by ethnicity and sex. We're seeing a definite change in this, though. This is state data, and you can see that historically males had a higher, we had a higher number of males that were overdosing, and unfortunately, females are quickly catching up, and we are almost at 50-50. These are the fentanyl and methamphetamine-related death rates, and you can see that from 2019 to 2020, they are climbing. These are overdose visits to the emergency department and urgent care centers. And in 2021, you're not seeing the data there, and I think it was because of COVID, and our numbers weren't high enough in essence to actually pull that data. There were 33 total overdoses reported in Essence. And Essence is the system that we use with the Oregon Health Authority to pull data from ERs, first responders, police departments to see how many overdoses are happening. But that's not a perfect system, and I'll touch on that in just a bit. These are ED visits by illicit substance and age. The majority of overdoses are among 19 to 40-year-olds. This is also changing. Joanne Miller with Samaritan and I have been watching the data, and we're noticing an increase in youth right now, and that's extremely alarming, especially because a lot of times they might dip into mom and dad's stash and they don't know about fentanyl, and that first pill could be the last thing they ever take. And so it's quite alarming. And one of the things we're really going to be focused on in the future is youth prevention programs. We're finding that prevention is definitely lacking right now. So these are our statistics from our harm reduction team for Lincoln County. And you can see that the amount of syringes that we've taken in and the amount of syringes that we've pushed out, we had a drop from 2021 to 2022 because we had some staff changes in our program. But part of this that I wanted to touch base on, just so that you guys are all aware, so Lincoln County Health and Human Services provides most of the Narcan for the region. Lynn, Benton, and Lincoln, I represent all three counties. And all of the funding that we have to purchase Narcan and naloxone to reverse overdoses, we are able to purchase because we write them into every grant proposal that we write. It's very costly, $75 at my discounted rate for a box of 2 doses. And right now, if fentanyl is on board, law enforcement is reporting that they can use up to 8 doses to try and reverse an overdose, which is just alarming to me. So just for Lincoln County, since January of this year, I've purchased 1,356 boxes of Narcan. And that's 2 doses per box. And in each harm reduction kit that we send out for opioid reversals, we include 2 doses, which I don't think is adequate. I think that we're going to have to start maybe including more as we watch the fentanyl rise. What that translates to financially is $101,000 in Narcan just for Lincoln County. So it is quite alarming, quite expensive. Lincoln County Health and Human Services doesn't have the bandwidth to do a lot of distribution events, so I rely heavily on our community partners. Phoenix Wellness Treatment Center just had a Narcan event with the fishermen and the fishing vessels. We have events with Reconnections and the Confederated Tribes of Siletz Indians Harm Reduction Program. And we are also distributing through our harm reduction program with our syringe exchange programs. But when I was talking to you about the difficulties with our data, you can see that most of this data was state data. It's really hard for us to drill down numbers and get data locally because of a few different reasons. One of them for fatal and non-fatal overdoses is if a person dies and it's unintended, it just depends on what the responding deputy or officer sees. You know, they're not necessarily going to run a toxicology panel if they don't see any drug paraphernalia or anything there, or they're not known to be a person with substance use disorder. And so sometimes on the death certificate, it could be listed like cardiac arrest, or other things and not always overdose. And that's been really frustrating for us trying to get the data. And another issue that we're having with getting the data is a lot of times, because a lot of our naloxone and Narcan is going out through our harm reduction programs, we are seeing that people are reviving people in the community. And so when that happens, a lot of times the person who has overdosed refuses to go with the first responders. They refuse to be transported to the hospital. And this was something that kind of stumped me for a while, but we learned from that the substance use disorder community that they didn't like to go to the emergency room because they felt that they were given too much naloxone and it brought them down too fast and they were experiencing terrible withdrawal symptoms that weren't managed very well. And if they were at home, they could self-medicate to help with that. But what's really scary to us is that we know that the opioids stay in their system regardless of the Narcan knocking the opioids off of your opioid receptors. And once it wears off, the opioids are still in their system and come right back onto those receptors. And if they've re-medicated themselves with another dose of heroin or something, that puts them at greater risk for fatal overdose. So currently, we are working regionally with law enforcement and first responders on 2 different data platforms that we're looking at bringing to the region. And for me, it's really important that we do this regionally because our population is very transient. And you know, if we're having a cluster of overdoses in Sweet Home in Lynn County, it's only a matter of time till we're seeing it here in Lincoln County. And so both of those platforms have been successful in larger counties, like Clackamas in the Tri-County area, Multnomah County. And the first one is called OD Maps, and it's a system that first law enforcement can use and public health to track overdoses. Every time they go out on an overdose, they use an app to report it. The second system that we're looking at is called First Watch. And what's unique about that system is that it can pull the data from all of the systems automatically so that law enforcement or first responders don't have to do another thing while they're out in the field. So later this month, we're having a meeting with some partners from the region to look at both systems to decide what's going to work best for us. And I'm hoping that'll give us a better picture of what's happening in the community. But as long as people are reviving people out through the naloxone and Narcan in our harm reduction program, every number that we get it's just a story. You know, somebody reporting that somebody reversed an overdose, and we don't really know that. You know, it's all anecdotal stories that we get back. And so we're working on trying to get this other standardized system, but we know that we're still going to have gaps in the data that we're pulling. So that's all I have to say about the data right now. We're really fortunate to have such a great partner as Samaritan and IHN CCO. That's where we get majority of our localized data, and that's how we can track what's happening right here. Again, keeping in mind that we do have some gaps. Thank you.
Thank you, Jennifer. So now we're going to transition to hearing from a panel. Several presenters are going to give us some great information about things that are going on across the county. So at this time, I'd like to invite our panel to come and have a seat at the table up here. And as Casey is getting us ready for the next, or for the presenters, I did want to point out to you that our Lincoln County Health and Human Services team recognized that there's probably a lot of terminology that you might not be familiar with. So they put together a definitions list for you on the back of your agenda. So if you're hearing some acronyms that don't quite make sense, there's some there for you. Our goal here today also is to use as much inclusive language as we can, recognizing that there's people from across a whole lot of different disciplines here. We have mayors and people from healthcare and people in law enforcement, and we don't all speak the same languages. So as we get to the sharing portions here today, I will also ask that people try to avoid jargon and acronyms so that we can all understand what you all are doing.
So Asian is going to get our screen back. So stay tuned for that.
Great.
Does your panel have a PowerPoint?
I think we're going to start.
Get out of the way. Sorry, thanks. Thank you. Well, there we go. Thank you.
Is Isabel on Zoom?
Is Isabel on this panel?
Yes, she's first.
Oh, she is. Oh, okay. All right. Stand by.
So our first panelist is joining us via Zoom, so bear with us as we bring her up here.
Okay, Isabel, look for the icon to move you into the panelist role. You should see her up here. Okay, let's check your audio, Isabel.
Hello, can you hear me? Can everyone hear me?
No,
We cannot hear you in the room.
yeah, for some reason it's not coming through, Isabel. Hang in there. Give us a test, Isabel.
Can you hear me?
Yeah, we can, but it's not coming through our main feed. Yeah. Let's see if we can work on that. Okay, try unmuting again, Isabel.
Can you hear me now?
Yes, we can hear you, but we found it. Yeah. I'm not sure. Okay, Isabel, give that a try. Give me a test 1, 2, Isabel. Oh, she can't hear me. Oh, okay. Sorry, you can't hear me. Okay, so what we're gonna do is we're gonna kind of move this microphone close to the computer as well. See if we can, stand by. Okay, she's unmuted. Okay, we'll go for it. Okay, Isabel, give it a shot.
Okay, can you hear me now?
A little bit. Yeah, do your best.
All right, let me introduce you first, Isabel, and I'll turn it over to you.
Okay, sounds great. And also I'm realizing that I probably won't be able to move the slides. So if someone wants to flip through slides for me, I will be appreciative. Please and thank you.
Okay, I'll do that for you.
Well, with that, I am pleased to introduce Isabel Cisco. She is a former health promotion specialist with Lincoln County Health Promotion, and she's a current Bloomberg Fellow at Johns Hopkins University. Let's give her a warm welcome.
Excellent. Can everyone hear me okay? If I can just get some thumbs up from the people on the panel, because that's who I can see in the room, if you can all hear me. Awesome. Great. Thank you. It's so nice to be with everyone today. Like they said, my name is Isabel Cisco. I'm a former health promotion specialist with Lincoln County Public Health. I worked on a grant focused on secondary prevention of HIV and hepatitis C, but also worked in our harm reduction program pretty extensively. ended my tenure with Lincoln County in the beginning of June when I relocated to Baltimore, where I'm currently working on my master's in public health at Johns Hopkins as a Bloomberg Fellow in the addiction and overdose focus area. So substance use and overdose is obviously an issue that's very near and dear to my heart. And something that I've spent an extensive amount of my time when I was at Lincoln County working in, particularly over the first part of 2022 when we observed a pretty significant rise in fatal and non-fatal overdoses in our community. But today I want to focus in on harm reduction, a different part of substance use, a prevention strategy that is evidence-based that I believe plays a big role in what we can do to mitigate the effects of substance use in Lincoln County. I can't see the room, so I was going to start by asking for a show of hands of who, if anyone, has ever heard of harm reduction or if you're familiar with the concept, but I think we'll just go on through and get started. If someone could switch the slide for me, please. Technology, it's great when it works. We love it. Excellent. Thank you, Casey. Go back one more. Thank you. So this is a brief overview of what we're going to talk about today. I'm going to start by defining a couple different terms. We're going to talk about what harm reduction is and what a harm reduction approach looks like. And then we're going to define addiction and recovery. From there, I want to get into talking about the need for harm reduction, its effectiveness, and the evidence behind the practice of harm reduction. I want to detail some of the great things that Lincoln County and our harm reduction program here on the coast has done. And then I want to talk about challenges and what our partners can do. And I'll finish with some links and contact info for you all going forward. Next slide, please. Excellent. So harm reduction, what is it? Effective harm reduction is an approach to reduce risk when abstinence is not feasible, practical, or acceptable. And it's been effectively used in substance use disorders and addiction treatment since 1980 in the United States, and longer than that internationally as well. And I want to be clear that I tend to think about harm reduction in pretty broad terms, right? Anything that we do in our daily life to reduce risk of something bad happening is harm reduction. When you get in your car and you put your seatbelt on, that's harm reduction, right? So I think that oftentimes when we hear this terminology, we think about it in pretty narrow terms with communities who are using drugs. And for the purpose of our conversation today, that's what I'll be focusing on. But I do want to make it clear that harm reduction can be used in a multitude of different ways. This approach is pretty multifaceted, and it's been proven to work pretty successfully in other areas outside of substance use and overdose prevention. So what does a harm reduction approach look like? Effectively, it's a non-judgmental support at whatever stage of readiness a person is at, and that includes not being ready to stop using substances. We want to look at the whole person. So we want to look at the social and behavioral determinants of health, focusing on how and why they may have started using substances and the supports and pillars that they have in their life. We want to recognize the influences of poverty, past trauma, discrimination, social isolation, and culture. I'll also add in there with 2020 and the events of George Floyd, I think it's also important to include the effects of institutionalized and systemic racism in that as well. And we want to ensure agency and empowerment. And this is one of the key factors of harm reduction, giving someone the agency to make the best health decisions for them and doing so in a way that empowers them to feel like they are in control. Next slide, please. So addiction. Addiction is characterized as a chronic relapsing disorder, characterized by compulsive drug seeking, continued use despite harmful consequences, and long-lasting changes to the brain. In clinical terms, we can also say that it's a complex brain disorder and a mental illness. And as a diagnostic tool, we call it a substance use disorder, which can be mild, moderate, or severe. And this is characterized by impaired control, social impairment, risky use, and physical effects, which are tolerance and withdrawal. Next slide, please. Thank you. And when we talk about recovery from substance use and addiction, we recognize that recovery is a continual process, it's growth, and it has resilience as a key component because there will be many, many, many setbacks on the road to recovery. And recognizing that recovery looks different for everyone. No one journey is the same. And so the processes and the steps that people take to get to recovery and maintain recovery is different, unique, and individual. There are 4 core components to recovery. So there's health, which is symptom management and making informed health choices for your person. There's home, having a safe and stable place to live and a stable environment. There's purpose, having meaningful daily activities, having independence, income, and resources to engage in society. And then most importantly, in my personal opinion, there's community. So relationships and social networks of support, friendship, love, and hope. And all of these things combine into success stories for recovery. So these are the 4 pillars that really hold up recovery for individuals. And again, unique journeys. No one journey looks the same. And our journeys in recovery are influenced by healthcare, supportive housing, employment and educational opportunities, and social supports within a community. And these are crucial to be able to lift someone out of substance use and into recovery and have a sustained recovery process. Next slide, please. So the need for harm reduction. Why do we use harm reduction? Why is it useful and why is there a need? And you'll notice that I've kind of put this interesting term up at the top, syndemic, which is actually a combination of 2 different words, synergistic epidemic. And I know that that sounds like a really academic term, but all this means is that a syndemic is that there are multiple epidemics happening at the same time that overlap and interact with each other and make the combined effect of those epidemics worse. And so when we talk about the syndemic model for substance use, we're looking not just at substance use disorders and injection drug use, but we're also recognizing the effects of the overdose epidemic, illnesses, and trauma. We're recognizing that sexually transmitted infections and communicable disease and poor birth outcomes are a part of that. Specifically talking about chlamydia, gonorrhea, HIV, hepatitis C virus, and then congenital syphilis and birth defects like fetal alcohol syndrome. Injection drug use infections like endocarditis, osteomyelitis, HIV, hepatitis C, skin and soft tissue infections. And then, of course, the epidemics of homelessness, mental illness, and suicidality. Next slide, please. So this is probably my favorite slide in the whole talk. It's a little messy, I know, but it's a really good illustration of what I mean when I say a syndemic overlap model. You can see here that there's multiple things listed on the slide: neonatal abstinence syndrome, injection drug use, substance use disorder, overdose morbidity and mortality, suicidality, sexually transmitted infections, HIV, hepatitis C virus, hepatitis B virus, illegal drugs within misuse potential. And you can see how all of these things are characterized. They overlap and they interact with each other. And so the combined effects of this syndemic model is a lot stronger than if we were just looking at injection drug use on its own. The reason that I put this in the talk is that I think it's important to recognize that in order to address substance use and injection drug use in our community, we really need to look at all of the factors that play into why someone is using substances, which include analyzing the social and behavioral determinants of health as well. Next slide, please. So the effectiveness of harm reduction. In areas where syringe service programs are available, so needle exchange programs that offer rapid testing, offer needle exchange to get safe injection supplies, offer naloxone kits. They provide a range of services, including disposal, sterile injection resources, testing, vaccination, and linkages to care. In areas in which syringe service programs are operational, we see that people are 5 times more likely to enter drug treatment and about 3 times more likely to stop using drugs. Additionally, there is 44% to 68% less likelihood of contracting HIV in areas where syringe service programs are operational. And we see an 80% lower rate of HIV, hepatitis C, and other bloodborne infections. Next slide, please. Syringe service programs also contribute to 20% fewer drug-related emergency department visits. There's a 1-year cost savings of $1,300 to $3,000 per client, and those savings include healthcare costs like visits to the emergency room, but they also include public work costs, so having to clean up syringes that are improperly disposed of in our communities. And the difference in the pricing there just depends on the type of environment and community in which someone is living in. Are they living in a more rural community, or are they in an urban setting? Syringe service programs also result in 8 times less improper unsafe syringe disposal, and increased syringe distribution linked to increased proper disposal, because when we provide syringes to someone, but also give them an avenue to dispose of those syringes safely, they bring them back to us. We also see that there's a 67% fewer needle stick injuries among law enforcement and first responders. Next slide, please. Next slide, please.
About 2 minutes, okay?
Okay, thank you. I'm almost finished. So in Lincoln County, this is what our program looks like. We offer a range of different services, from HIV and hepatitis C testing, navigation into care, resources for basic need, naloxone distribution, and free syringe disposal. Next slide. Here are some photos of what a typical needle exchange event would look like if you saw us out in the field. Next slide. As well as our mobile outreach van, which our harm reduction worker drives around to make services more accessible to people who can't get around as easily and meet us. This is the whole meeting them where they are approach. Next slide, please. So some challenges in harm reduction. There's always a need for continued support and awareness from community organizations that we partner with. Additionally, having access to people where they are is crucial to our methods in harm reduction, because there is instability in housing. I think we all realize that out on the Central Coast, housing is a real challenge, and there is a huge issue with houselessness, displacement, and transients in our populations. There's a lack of local available resources like shelters and hygiene facilities, a lack of close coordination and data sharing between the different systems involved in overdose prevention and substance use prevention work. And then additionally, there's stigma, judgment, and discrimination against people who are using drugs, as well as the past trauma that they bring with them when they engage in services with our harm reduction program. Next slide, please. So what partners can do: provide us access to clients, work with us, partner with our harm reduction program here on the coast, so that we can make those bridges between our different systems and access people more readily. We can coordinate services, so we can have referrals to harm reduction workers, and they can offer complementary services like having a condom basket out on the front desk of your organization. And we can advocate for harm reduction. Tell us the services that you're ready for, and adopt non-judgmental language and services in your organizations yourself. Last slide, please. Lastly, I wanted to provide some links in my contact information in case anyone has any follow-up questions or concerns. Links to the harm reduction webpage on Lincoln County's website, as well as the Facebook page for our harm reduction program, and then my contact information displayed. Thank you so much for your time. It was really nice to see some familiar faces and those of whom I have not met, and I'm happy to be here and for the rest of the symposium. Thank you very much.
If you have questions for Isabel, I'd ask you to hold on to them until the end. We may have time for a few questions. But I'm pleased to introduce our next panelists. We have Faith Brandenburger with Reconnection. And Faith, would you be willing to introduce your partner?
Carissa McGrain, also with Reconnection.
I'm Faith Brandenburger. I'm the clinical supervisor at Reconnections. This is Carissa McGrain. She's my partner in supervision, and she's our program manager. We're doing pretty much everything together, and we're each other's supports at work. And yeah. So
Driving change.
Drivers
Exactly.
change. So I've worked for Reconnections since 2006, and I would not recognize our program today from then. In 2006, when I started, we were abstinence-based. Everything was pushed towards abstinence. People signed an abstinence contract. There was no harm reduction. Harm reduction was just coming on board, especially in Lincoln County. There wasn't a lot of information out there about it. I came from San Francisco, where there was a lot of harm reduction. And then when I came home to Oregon, I found there was very little. So it was very easy for me to adapt to harm reduction, but it took us a long time as an agency to transition from being simply abstinence-based to moving towards really a continuum of recovery. At Reconnections, we look at recovery as a continuum. It starts at the very bottom with where it's just harm reduction. That's all we're doing. We're just keeping people safer, keeping people from dying, and helping people move us, we can help them move to the next step. The end goal, of course, being abstinence, because really, honestly, we want to see what people can become. We want to see who they become abstinence in their life. We want to see who they become drug-free. We've seen amazing changes in people, but we didn't see those changes as much when it was forced, when we had to start abstinence, when we were like, we walk in our doors and we're like, today starts abstinence. Today's, and we're going to report everything that's going on with you. So we've really adapted over the years, and it's been a slow change until about 2018, 19, when it was just like blown open. We're like, okay, we're doing things differently. And this is the great part about being who we are, is we get to change things at the spur of the moment. We decide this isn't working anymore, so we're going to change something. And we decided to take a harm reduction approach and to incorporate it with our abstinence-based. So we still have abstinence-based programs. We still work with drug court, which is an abstinence-based program. We still work with Department of Corrections, which is mostly an abstinence-based program. But we've incorporated a lot of harm reduction things to get people to where they're at a point where they can do that. So we've seen a lot of changes in the last couple of years. So we've implemented a bunch of new programs, and we're going to talk to you about those programs as we can. We know we only have 10 minutes, so we're going to kind of run through them. But we've really seen these big gaps in the community, and so we're trying to fill them. We luckily ran into Jennifer at the OPOC conference in 2019. I think it was summer of 2019, and she's like, OHA is doing this great new program. I think you guys would be perfect for it. And I think in 2 weeks we had it started. And we started it that fall, and that was Prime Plus. So the new programs we have, Prime Plus, we'll explain each one: FAIR and pre-FAIR, Nurture Oregon, LEADS, and then the programs we've always had: intensive outpatient and outpatient treatment. And then in 2018, 16, 18, those are I know. She's got to be straight. In 2016, we started clean and sober housing programs, and it was for women only at that time, and now we have a men's program. Better you than me. So Prime Plus is the program that we started with Jennifer's help. She introduced us to the OHA. She helped us with the grant stuff, everything. So the Prime Plus peer program connects peer support specialists with anybody in the community who's at risk or currently receiving treatment for overdose, infection, or other health-related issues from their substance use. It started out strictly opiates. That's what it started out as. We were treating people with opiates. We were supposed to be in the hospitals. That was supposed to be our primary focus, was putting peers in the hospitals. This is, in 2019, COVID hit. We weren't allowed in the hospitals. We think everything kind of came to a screeching halt shortly after we started this program. So we got inventive. We started going into the jails. We started going to primary care. We started working with as many doctors as we could in the area. We started, where else were we going? Prime Plus. We were working with everybody. We started collaborating with public health to do syringe exchange and to work with them to show up at the syringe exchange, hand out cards, things like that. So Prime Plus peers engage individuals regardless of their enrollment in a treatment program. They don't have to be enrolled in our program, in any program. They don't even have to be ready to quit using. We're there just to try and help them through and maybe take them to the next step. So it doesn't matter what stage of change they're in, we'll meet them there. And our goal is not, to walk in and change your life immediately. Our goal is to walk in and move you one step forward, and then one step forward from there. And if we keep moving you one step forward, eventually we get to the end where we can see who we want to be. So we do linkage to substance use treatment and recovery supports, linkage to physical health care, support for infectious disease testing and treatment. So we work with Jason Brown at Toledo Clinic, and he has given us all the paperwork that we need. If somebody knows that they're Hep C positive, we can send it in the lab work with them, walk them down, they can walk down to the lab, the peer can take them down to the lab, get lab work, it's sent to Jason, we make them an appointment. By the time they get their appointment, he already has their lab work back and knows what kind of medication they need, and he's willing to treat them whether they're using or not, whether they're still using substances or not. In fact, he tells me to bring the whole cohort. He says, bring them all. Everybody they're using with, bring them, we'll treat them all. And so that's been actually a really successful collaboration that we've had. We do access to community resources, meet basic needs. We support people in getting their Oregon health plan turned on or getting Oregon health plan for the first time. We access to harm reduction supplies. So we've worked with the county. They do harm reduction at our annex building. And so once a week, they're there for a few hours to do needle exchange, to do testing. It's great. And then we do emotional and crisis support for Prime Plus. Okay, so the next program I'm talking to you about, sorry, we're going really fast, but I know we don't have time. So we're doing fair and pre-fair. And so those come out of the Oregon Social Learning Center in Eugene. And our supervisor for that is Lisa Saldana. She's a PhD and she runs the Oregon Social Learning Center. She's amazing. And she designed this program. And FAIR was designed to address the needs of parents referred to child welfare services for substance use. So look at parenting deficits, mental health symptoms, and ancillary supports.
Primarily for opiate use disorder and stimulant use disorder.
Yes, although us being the agency we are, we've been able to adapt that and incorporate marijuana and alcohol in as well, where other programs have not been able to because of the testing features. So the community-based outpatient intensive behavioral treatment involves 5 major components. So the first component is teaching and supporting parenting skills. So everybody in FAIR and pre-FAIR is a parent. So we're really looking at creating healthy coping skills for being a parent and creating healthy parenting skills. More than anything. So we look at nurturing and attachment, reinforcement, emotional regulation, supervision, non-harsh discipline, and nutrition, which a lot of our parents don't have any idea. Number 2, substance use treatment. So we do contingency management. We have a FAIR score that's full of really fun stuff. Everything like from basic household needs to, crazy stuff the kids are gonna love, or, we have little baskets for the kids so that we're starting to incorporate kids into it when the kids do well or follow their parents' orders, whatever, they get to pick something out of the basket too. And they get FAIR bucks, and it's on an app or on paper if they don't have access to it. And we give their FAIR bucks for every positive thing that they do. So if one of their struggles is getting up out of bed in the morning and getting their kids ready for school, they get up in the morning, they get their kids out the door, we're gonna give them FAIR bucks. They give us a clean way, they're gonna get FAIR bucks. They show up for an appointment, they're gonna get FAIR bucks. And then we get to work with them in the store and work on budgeting and work on like prioritizing and deciding what your actual needs are. And then, so then resource building, we do a lot of ancillary support. So we help them navigate for housing, we help them navigate employment, support with court and child welfare meeting attendance. Healthcare, absolutely. We go to visits with them, with their kids, so that we can help coach. And then we talked about the incentives already, and then ongoing engagement. And then pre-fair is just a quick thing on pre-fair. Pre-fair is for ages 16 to 30 only. It is a research study, so it's being funded, and it actually gives them monetary incentives along the way. Okay, there's more information on the desk.
And so then we have Nurture Oregon. So Nurture Oregon was another program brought to us as a partnership through OHA. Very briefly on this, because I can actually give you more information in the slides. So Nurture Oregon is to work with pregnant families up to a year postpartum and helping support healthy pregnancies and healthy birth outcomes. And so we work with families that either are currently struggling with substance use disorders, or maybe there's a past history that the current pregnancy might pose a high risk for relapse or recurrent substance use. And so we have a team of providers here in our area. New Connections being one of them, offering peer support and doula services, because our 2 Nurture Oregon peers are also certified doulas. And we're able to go with them to doctor's appointments, coordinate care, care through other providers, such as the county internal management programs and things like that. So, and then we also participate in the county or with the Sheriff's Department with LEADS, the Law Enforcement Assisted Diversion Program. Again, this is a harm reduction approach, which we're trying to help get people engaged in services rather than incarceration. And so we work with our local law enforcement in order to see who is more appropriate for these services. And we also provide supportive housing as well for up to 1 to 2 individuals, depending on compatibility.
We'll skip this part because we've already talked about it a little bit.
And then again, we also offer sober housing for both men and women. We have the recovery house for women, and we have our gold house for men. And again, we have our LEADS house as well. For our recovery houses for the men and women, it's about a 12 to 15 month program offering supportive services, structured living, as well as life skills development and self-sufficiency, as well as helping them find permanent housing.
Plus, we have a lot of information. We're going to have any time. But then we do have brochures over on the table. And if you have more questions, please feel free to ask us or call Reconnections and ask one of us at any time.
Thank you. So much information. Please do grab the brochure. So our next panelist I'd like to introduce is Jamie Burris-Fish, who's a nurse practitioner who's going to talk to us about office-based addiction treatment program. If you're wondering about that acronym, that's on the agenda. It's on that. Give Zadie a warm welcome.
Okay, thank you. Thank you, everybody. I work, as they said, with Lincoln County Health and Human Services. I'm a psychiatric nurse practitioner as well as a family nurse practitioner. And when I started in 2019, they part of the job description was that I would get waivered to prescribe Suboxone as we were looking at starting a program. We worked with various entities in the community. Samaritan was working on a grant and worked with them to help get some of the funding. We also had worked with Boston Medical Center in Massachusetts. They have a really good program for training how to open up a clinic to treat people with substance abuse disorder. Initially, when we started our program, it was in February of 2021. It took us a while to get our policies and procedures. And also there sometimes has to be a lot of training of your staff, because number one, when I started working in primary care for the psychiatric patient, there was a lot of concern that we were going to have all these crazy people and, oh my God, what are we doing in primary care? Well, we're all people and you're already seeing these people and we're here to treat them. And I feel like this has been a very great job for me because I can work with their primary care providers as far as what medical needs they have. A lot of the patients that we serve are indigent and they don't usually go to see a doctor. And a lot of times they don't really want to come in to see me, but it might be that, you know, they've had depression for a long time, they've been in the emergency room. So I might be the first person and I'm doing an evaluation of their psychiatric needs. During that, I find out that they may have substance abuse issues as well as medical issues. So we really work together to coordinate and just to do whole treatment for our patient. Our very first patient that we had in our clinic, in fact, was somebody I'd been seeing for depression and anxiety. She was not forthcoming that she had a substance use disorder, but she developed an abscess and had to see her primary care physician. So she did ask for help. She's still in the program. And a lot of times, one of the things here, it says, what are your successes? And I think that depends on what your idea of success is. Sometimes just having the people come and keep their appointment, you know, they may still be using other substances, but they're still taking the Suboxone. Just showing up to me is a success. And we have currently, just right now, only 22 patients in our program. Part of that is because of our scheduling, and also currently we only have 2 people that are waivered in our clinic. We have, with the burn grant that I know Jennifer is probably going to talk about later, we're hoping to get one provider that's what they specifically do is Suboxone treatment, so we can get people in quicker and get them started. We also had a office-based addiction nurse who would meet with the clients. She would screen them, she'd do an initial evaluation, and then she would the providers to see whether this person met the criteria or not to be in the program. And we've had a lot of changes since we first started our program. We've had, you know, lots of learning experiences. I started in the early part when Suboxone first came out in another clinic, and they were very strict. You had to be abstinent. You had to attend this many groups. You had to do so many urine drug screens. And it was only for a temporary amount of time, then that changed that you can be on Suboxone for the rest of your life if that's what you need in order to stay sober, productive, and having a good life. Most of the clients, as everybody else that has talked about, the social determinants of life, most of the people have had some childhood traumas, and we also will do an adverse childhood event screening just to see where are we starting. You know, did they have parents that used, did they have suicides, that kind of thing. And that gives you more information on how to reach them as far as what their goal is for coming in. Sometimes it's because they're in some type of legal program and they have to do it for that. But we try to make it where you're doing it for you, you're doing it for your family, and you are a person. You have a lot of capabilities, and we want to kind of build up from that. So part of our program is you come in, you meet with Sarah Vogel as our office-based nurse, and she will do a screening over the phone. She'll have them come in and she asks a questionnaire. She talks to one of us. Now we will give a tie-over until they can get in with one of the providers. So it might be I give a 2-day supply. I haven't really seen the person, but that's going to get them back into our clinic. And then we try to get them a physical evaluation to make sure that we get all the testing done that they described with the harm reduction. We do have a program where we can treat Hep C, also HIV, and mental health. I do a mental health screening on every patient that comes in. And I end up treating a lot of them for depression, anxiety. There's a lot of co-occurring disorders with substance use. And like I said earlier, there's still a lot of stigma with mental health. It hasn't really changed a whole lot. We do have a large homeless population. And the way they are treated sometimes is very unfair. Who chooses to be on the street? Who chooses to really use heroin? You know, the epidemic with opioids started a lot with getting pain medication. And hey, this makes me feel good. And recently, I have more empathy for people in pain because I need a hip replacement and a knee replacement. And you don't get those, you don't get medications for those things. But we have to think about the emotional pain that people are in too. We have had one successful female that came in, wanted to get pregnant. I switched her to Subutex. She had a baby with no issues at all after delivery. She's moved to a different county, so she'll follow her treatment there. But there's just a lot of things that people don't know, and our program is growing. And if you have any questions, we also have a paper over there. But I do feel like we really see the person as a whole. And Jason Van Erickson is our other provider, and he's the nurse practitioner. We're hoping to get more people waivered, and then SAMHSA has really changed what you need as far as becoming a waivered practitioner, because not every doctor wants to do it, and sometimes it's just what they have in their mind, why, the type of people they're going to be working with and all the things they may have to deal with. And you really will be surprised if you actually do treat people with a substance use disorder. I've learned so much from them, what resources are in the community, and we're all people. So that's, I think, all I have to say. If anybody has questions later, they can ask me.
All right, the next presenter I'm pleased to introduce is Ruby Moon. She is the Community Health Director with the Confederate Tribes of West Indies.
All right, go for it.
Can you guys hear me? Yeah. So, good afternoon. I'm Ruby Moon. I am the Community Health Director for the Select Tribe. And very low truck, so I don't have a PowerPoint for you guys, but I'm going to talk to you about a few things that the tribe is doing and then how to where I'm at. So I think I'll start with my own story. So I've been with the tribe for about 6+ years now, and I started doing harm reduction work about 4.5 years ago. And my interest in that came from my own experience. So I have a daughter who is has just over 2 years clean now, and felt like I needed to learn as much as I could about what was going on for her, how to help her. There wasn't a whole lot going on. That was the passion that drove me to make harm reduction a reality for where I work and for the work that I do. And so luckily I got the opportunity to partner with the county on an HIV STI grant. And from there, we were able to build out our harm reduction program. So we do STI testing, HIV and Hep C specifically, and then are able to do clean kits and needle exchange as a result of that work that we're doing there. One of the unique things about working for the tribe is that all of these great things and all these things that are happening out in the community actually are happening right in Celeste too. So we have this beautiful clinic, this beautiful facility that has behavioral health in it, which we got Dee out there. She is running the behavioral health department. She can talk about that. So that's a pathway for people that want to get recovery. We have our MAP program, Mason's out there too, that is able to do MAP if that is a person's decision for their road to recovery. And then we have harm reduction. Harm reduction is nestled in community health, which we have an array of services. It feels like a really good fit because we are about the community and that's who we're serving. And you know, it is about people. It is about people, 100%. And so one of the things that we really like our platform that we are trying to lead from is we have this coalition that's been going long before me, 20+ years, called Cedar, and it's all about bringing people together and having connections in the community. And it used to be that, and it still does serve as folks coming back into the community and healing and being in recovery and celebrating those people. But as we dug into that work, we really realized that, first of all, recovery, everybody's road to recovery is different. And we wanted to acknowledge and celebrate all of that. But trauma is a huge part of disconnection. And so being able to have that forum where people can come together and really celebrate each other and feel connected to the community is pretty fundamental in the work that we do. We never stopped working when COVID hit. That never happened. We actually increased our harm reduction team, increased the amount of naloxone and clean kits that they were distributing in the community. On the average, we usually do probably about 9,000, take in about 9,000 needles per quarter. And this last quarter that we just reported was 19,000. So that is a huge increase, and I think that speaks to, you know, what's happening in the world, really, people's mental health and our ability to cope. And so we're that first line, we're that first trusted friend that reaches out and says, "I'm gonna help you no matter where you are," and there's no judgment associated with that. It's me and you and that relationship. Things are a little bit different. I loved, everybody's touched on a piece of it, but I loved what the slide that Isabel shared that showed what a normal site looks like, a normal exchange looks like. That's a fixed site. That's very different from how we do business out at the tribe. We are, so it's a really tiny community. There's like 1,200 of us out there, and we are serving tribal members in the Celeste community. And so everybody is related or knows each other very well. That's how it happens in a little tiny town. And so we do exchanges very differently. We have tried fixed sites, and we definitely partner and are willing to be good partners and come alongside you for events that you're doing. Just doesn't work that way yet. I have hope. It doesn't work that way yet in the Celeste community. Really, that's a phone call to that really trusted partner, that harm reduction worker, and we'll meet you out back by the yurt, or we're gonna meet you behind the grocery store. So it looks very different. Offering the same services, I think that we've been able to trailblaze in a lot of areas because those decision makers are, family, and it's a close knit community and your neighbors, and it's much easier to cut through the bureaucracy of policies and rules. And not that we don't have those, we absolutely do have those, but they're easier to create. So I actually think in the county, we're the first ones to distribute naloxone. So got that jump and are still moving at a fast pace forward. It's changing and evolving and shifting to meet that need. But I think one of the things that I'm most proud of anyway is when people do come. So we do all the things like how we get on organ health plan, get into treatment if that's what we choose to do. Whatever it is, we let the person decide. I mean, you get to decide for yourself what you want. One of the things I'm most proud of is that all of those support services to be successful, from transitional housing to treatment to mental health to the MAP program to just primary care, all of that is there. That's a pretty amazing thing, and I think a removal of a huge barrier for lots of folks to be able to connect with that person one-on-one and let them come beside you and be an ally to get you to where you want to go. So that's our program. Thank you guys.
So the next person I'd like to introduce is Sheriff Landers. He's going to talk to us about what is going on with the County Sheriff's Office.
Thank you. And I'm Tech too. I don't have a PowerPoint today either, but I want to start off a little bit by talking about not only what we do, but how we got here, and kind of personally the culture shift that I made working here in law enforcement for almost 35 years, and going back to the early 90s, and kind of just how back then it was more of, do the crime, you do the time. No matter what quantity of drugs, you go to jail. It was really the Lee County Jail. The new jail was built in 1992, opened in 1992. Several prisons were opened around the state. Really just thinking we could warehouse ourselves out of this problem. And we learned that not only substance use disorder, but other behavioral issues, we could just warehouse this problem. 90% of these people are going to get back out in communities again. And what's going to happen, what we're doing is we're creating our own revolving door, and it was just involved. People just going right back in or committing crimes. But it really took me a long time to realize that till it was really other statistics as far as our jail population, our force releases, that really steered me to the direction that we need to do something else. We need to address the root cause of the problem and not just warehouse people and put them away. Doesn't mean that there's a lot of people that should go to jail, and but it was really what started was a pretrial justice program, and Judge Lockhart and myself, a number of other people from our community went there and learned about that. It started out from a conference that I attended in 2017, where learning about what can we do differently, how can we better address this problem that we are having, and really more effectively manage our jail populations so that we could get people to the things that they need. I think one of the things, culture, as far as the shift that I had, is just how strong this addiction is. And I still don't know it, obviously, but it is such a strong addiction. And one of the conferences that I attended, a doctor was telling us that if you are trying to diet, or if there's a food that you just cannot resist, French fries for me, something like that, just multiply how much you want that when you're hungry by 1,000 times. And that's what people that are suffering from substance use disorder are going through. So it kind of clicked in that really jail's not a deterrent anymore. And people in jail are telling me this. I'm walking through and they're going, I'll be out in a week, Landers, don't worry about it. I get back to the drugs. I can go back out to what I was doing, crimes I was committing, because we can't keep you here this long. And we were forced releasing so many people that they're going right back out without any plan. They end up going to courts, and then a lot of them are going to prisons again, no plan to get them. So what we really realized in pretrial was not just managing that population in jail, but how can we get people the services as quickly as we can so that they can address that problem. And one of the things we're able to do with the help of the commissioners and some other grant funding is to get our pretrial program going. We have 2 pretrial specialists, we have a pretrial counselor now, who really is addressing that population as soon as they come in to see what they can do. It's really initially to effectively manage the population, so we knew who could stay, who could go. But what I'm seeing is a lot of problems are being addressed early on. Our pretrial counselor, Amy Yates, is addressing things really quickly and getting them that direct line to treatment as quickly as they can, working with the courts to help accommodate that. Dennis Buckmaster, another counselor we have in the jail. We're so lucky to have 2 counselors in the jail. A lot of jails don't have any. Really work on that programming aspect while they're in. We were able to get a MAP program started. We only have capacity for 8 right now. And that's another thing that people, again, I walked through the jail and now they're asking me, how can I get on that program? How can I get on that list? I got to get off this stuff I'm in here, or I'm just going to go back out and use again. And it's sad to hear those things. I don't want to spend a lot of time Measure 110. While I was optimistic it was going to do some good, I don't see it yet. I don't see it getting people into the treatment that they need. It's really not. Sometimes it takes that enforcement effort, and we heard Reconnections talking about LEAD. One of the things that I heard about early on in these conferences, get these law enforcement assisted diversion programs, still keep them away from jail, but get them in treatment. This is really lined up for the people that, where it started as King County, Washington, where they were seeing people that had 50 arrest cycles going on and would be arrested for whatever kind of charge it was, but usually drug related. And they were just saying, well, they're going to jail, it didn't matter, but they gave them an option to go something else. And what they're seeing is that they were changing their behaviors and they were not coming back to jail. So huge business decision right there just to keep that going. But unfortunately, with Measure 110, and I hope that there's some changes coming to that, we're not getting to those people. We're having to get to them in other ways, and we've still been very successful with that. That's still been difficult to address. Initially, when we started LEAD, we didn't have Measure 110, so we were finding all these people that were going in there, and it's good. COMET program, our community outreach and mental health enhancement team was going for a long time, and was seeing a lot of things. What was initially addressed to look at the behavioral issues, what we found that they were finding a lot of people with substance use disorder, and again, getting them to the resources and services that they need early on before they're committing crimes, where they're going to jail. And we hope someday to bring that back. I want to touch a little bit on something that we're not doing yet, but thanks to a lot of efforts that Judge Bockhart has done, bringing back the drug team in Lincoln County. As a lot of you know, around the country, law enforcement is suffering with staffing issues. That's the one thing we have to work on first, but I know that a lot of cities are very much in support of this. I've actually adjusted one of our positions and we're able to get staffing back up with all the agencies. We want to build up, we're talking about it monthly with our law enforcement partners to see how that's going to look, because a lot of things has changed since Lent was there. I know that Dave Broderick was instrumental in Lent. He's even said, a lot of things have changed. Measure 110 is one of the things that I've found. But one of the statistics that show that we need that balance, I know Commissioner Hall hit on a little bit during her presentation earlier, is just that we have a lot of services going on, but we really need to balance that with some enforcement. Really, the enforcement is the one thing that's not happening in Lincoln County that needs to happen. And one of the statistics that I pulled is between 2018 2021, the number of drug seizures for pills containing fentanyl increased from 68 in 2018 to 635 in 2021. And the number of pills from about 290,000 to over 9 million pills. That's only the pills that were seized. I mean, you can compound that a lot by how many pills are still out there or getting in the wrong hands and causing what we're talking about here. So even though the rules have changed, search laws, decriminalization of things, we still think putting together a drug team will really have a good approach to it. Again, it's still tied in with not just warehousing people, not just putting them in jails and prison, but getting them to the resources that they need And a lot of times what's happening is we're seeing that these dealers, obviously they don't care about it, it's a business to them. So we need to address that. And then so we can help the people that are addicted, because again, going back to my, that really thinking about how bad that addiction is, and how people, again, it's jail's not a deterrent from them. And now it seems like death isn't even a deterrent for people that have this huge addiction, and it's so sad that we need to address that problem and get people the help they need. So I'm looking forward to that. And again, thank you for the good turnout and working with all these excellent partners. And I'm happy to answer any questions when the time is. And thank you again.
I'm excited to introduce our next presenter, who is Joanne Miller. She is the Community Health Promotion Director with Samaritan.
No, I'm low tech to the last we're all the low tech. So I appreciate it, and thank you, Sheriff Landers. I always admire you, Sheriff. You got the best sheriff in Oregon right here in Lincoln County, and the best sheriff team. These officers are amazing. And I don't know the other ones, I'm sorry, but these are the folks I've worked with, and they've been so amazing to work with as a partner with Samaritan and in your community, because when I came here 13 years ago, they were already working together to do things around substance use disorder. So you have one of the best teams in Oregon right here. So thank you so much. Continue the great work. So Jennifer roped me into talking about the STARS program, which is our Samaritan Treatment and Recovery Services. It is our residential inpatient substance use disorder residential treatment facility that's located in Lebanon. It's a 16-bed residential facility that houses 8 females and 8 males. It has that capacity, and thank goodness we're back up to capacity. Of course, during COVID, we were unable to operate due to state regulations, but now that the regulations have been lifted and we're now back up to full capacity with serving folks that were desperately needing residential treatment in our area. The STARS program is designed to serve anyone in Oregon and outside of Oregon, but the priority is given to our 3-county region. So we always want to take care of home first. We do provide gender-specific groups, and that's groups around clients who identify by their gender, and we prepare those groups to serve those folks. There's 2 outpatient groups per week that are intensive, and we have more intensive male and female groups. Men are 3 nights a week for 3 hours, and then we have females 4 nights a week for 3 hours, 4 days a week for 3 hours. They operate differently. We're not a detox facility. So the STARS program was never designed to serve as a detox, but they do offer what they call ambulatory detox services. This is for patients who are able to participate in their recovery and while they're detoxing, and able to take care of themselves so they can be sent home and then come back in for treatment and recovery services. And so that's pretty much all I have about the STARS program. I can talk to you a little bit more about our federal grants that we have been successful in receiving and partnering with Lincoln County Health Department, the Confederated Tribal Select Indian, the Sheriff's Office, of course, that we have been really fortunate to receive a couple of grants from HRSA over the past 4 years. The first was a planning grant that allowed us to Samaritan to look at the healthcare side of our services in the big picture and provide partnerships of what we really needed to do to support families, youth, and adults in Lincoln County around substance use disorder. After that planning grant, we were able to take that grant activities and implement those priority services that were identified by your community. It was a strong partnership that folks said, these are the things that we need to see happen. And as a result, the OVAC services are being provided, the CEDAR program reestablished. at the tribe with the tribe, as well as some harm reduction activities, and then looking at some prevention services through a media campaign and media awareness around opioid and substance use disorder. We're keeping our fingers crossed because we have submitted another proposal to address substance use disorder in Lincoln County to HRSA, and that grant would target pregnant women and youth. As Jennifer mentioned earlier, and we just began to take a notice that there's no services for young people, and we're seeing an increase in overdoses of young people. Unfortunately, it was an 11-year-old who overdosed, a 13-year-old and a 15-year-old. They were in Lincoln County. I don't know if they were fatal or not fatal, but when I saw that 11-year-old, my heart sank, because that's somebody in 6th grade that's going in that direction. So we need to put something in prevention. We need to go back to that prevention model. So in this current grant that we're hoping, keeping our fingers crossed, we'll find out in August, it would bring back and bolster the PATA group that would be able to do a lot of work around prevention services and support for young people in Lincoln County. If we're successful in getting this grant, what Jennifer also mentioned, and I noticed and shared with her in our June numbers of overdoses that are showing up in our emergency department, the tide has shifted. The number of females showing up at the emergency department is outweighing the men. We had 20 overdoses in Lebanon last month, and 14 of them were females. You had 7 in North Lincoln Hospital, and four of the 7 were females, and 1 in Pacific Communities Hospital last month, and that was female. And the neonatal abstinence births are also going up, so that is a true indication that women need to, and females need to be served and outreached and provided some support. And so we're hoping that this grant, if we're successful, we will really provide Lincoln County with some additional resources to provide some service support, especially in our prevention. So thank you so much for having me, and I hope that I can answer the questions you may have.
At this time, we do have some time for some questions for our panelists. Anyone have a question you'd like to ask?
It's on the bottom, Rachel.
So one of the questions was for the STARS program. I was actually talking to someone recently, and they were suggesting that I refer one of my clients to the STARS program, but I was wondering, are you guys dual diagnosis? Do you have the capacity to serve people? Okay, wait. Do you have the capacity to serve people that have mental health diagnosis? Like, she's not high needs mental health, but she definitely needs mental health. Oh, okay.
We have both mental health services and substance use services. Ursula may be able to answer that because she's been doing a lot of research. She's right behind you.
Okay, very good. Hi, I'm Ursula Barrio. I am the foundation director here in Lincoln County for Samaritan. And I have to really do that because I'm going to talk in a couple of minutes about the Coastal Stars program that we're going to create. And I have been talking a lot with Lamont Morgan, who is the operations director at Stars in Lebanon. And we, what we can do with Stars is when people have a dual diagnosis, if it is something that within the residential setting, they do not actually have the staff to be able to provide that counseling, but they do facilitate the counseling, mental health counseling. So whether that's Zoom meetings or facilitating getting them to their appointments, that sort of thing, they coordinate, but they don't have the staff to actually offer.
So how long does it take? How long does it process? Yeah, hello.
All right. So I was wondering, how long does the process take to get into you? You were saying like you can offer a client a 2-day supply, and then they come into you for physical, check for Hep C, HIV, all of that. But how long does it take to get into you for the initial appointment?
We try.
Or maybe I don't know how to do it.
Okay. Once they call our RN, that we could screen them the same day, get them a prescription, and I use the 2-day just because we try to get them in with somebody as soon as possible, just to continue their treatment. So we could get somebody in a day. We haven't been actively recruiting right now just because of the staff shortage. But we do get referrals from other people in the program. Or also, we work very closely with Reconnection. They help us a lot with their peer support program. We are going to be having a case manager start in August, and so she will do some of the work too with the nurse to make sure we provide transportation. The biggest issues that I see are transportation to appointments and also the living situation. It's really hard for a person to stop using if their partner is still using. And we do encourage, try to get both people into treatment at the same time. The fact that we only currently have 2 waiver providers, and I have a very large behavioral health population, and Jason has very high level of people for physical health. We do have openings in our schedule 3 days a week, so that we can get people in either for follow-up or for initial evaluation. And then we may make further appointments from there. Like Jason may see them do the physical. I can always add the labs, but I don't do the physical. I might do the psychiatric part, but we can still get them on the medication and get them in.
So say I have a client with me and they're like ready, right? And like for instance, we've gone to the door there and they're not.
Right. How do I get to do that? There is a number that they can call, and that was one of the issues that we had. We lost the nurse that was working very closely with harm reduction and also with Reconnection. And she had a cell phone, and it was a number that patients could call her or text. That was another issue. People might have a phone, but they may not have any minutes, but they can text. So that's a way, and now Sarah has that phone. There is another line, but making an appointment anywhere, you have to go to this person, and I hang up if I was in withdrawal. And so having one set dedicated number that they can call, and if she can't get to them right then, she'll get to them as soon as she can.
I know, in some cases, I would say, go to the emergency room.
Right, and we also, part of our package that we give patients, we list the other providers in the community that prescribe. We also list all the other treatment facilities. Unfortunately, a lot of people think in behavioral health and substance use, all you need is medication. And it's a lot more than that.
Yeah.
Because when you start getting sober, your problems really come to light. And one thing I hear over and over again is, I didn't think I would have all these medical problems. I thought I was okay when I was using. Well, yeah, because your brain is under the influence of a substance and you're not feeling those other things. And so it is part of recovery. And that can be depressing. People think, I'm going to take something, I'm going to feel great, I won't have any problems. that's not reality. And we really try to teach them a lot about that, patience and, you know, get in therapy, get in some kind of treatment, have a support system. So many don't. So we try to help them get that.
We have time for maybe one or two more questions.
I'll ask. I can just talk really loud without the mic. My name is Georgia, and I work for Project Bravery, which is specific LGBTQIA2 spirit plus youth. Within the programs that are already working, are we making room for gender diversity, specifically trans people, where maybe they don't identify directly of what we think a woman is, what we consider a male to be, they may be even non-binary. But making sure like that there's not the segregation between the two genders within programs. So what are we doing to really make room for that population, either for the future or what's in the program right now?
Well, we do treatment for people that want to go through the transition. I see quite a few transgender people, non-binary, we use although whatever they say or identify as. We don't have a specific therapy or a specific, we treat anybody regardless of anything. You know, we're here to help you, we want you to live. And so you're welcome to come. And I really feel like I said, initially when we started and we started talking about, we're going to start this program. Well, people have in their mind, oh my God, this is what heroin addict is, this is what, you know, and it's doing the education about shame. That's why a lot of people don't come into treatment, because if you have somebody at the front that says, oh God, you want, you know, you can tell a lot from facial expressions. And so we really worked hard with training our staff on stigma, empathy, and, you know, accepting. Because you're, like I said, we're all people. If you know their story, you would know why they were in that situation. We don't know that story yet, so that's how we have to kind of connect. And you get a lot more success if they feel like, gosh, you're listening to me, you're seeing the other person. I'm not, you know, they go to the emergency room, and if you say the word pain, you know, it's like, oh, they're here, they're substance use. And a lot of times, I've had patients that had severe medical issues that could have died because the person that saw them had that mindset. You know, so anyway, that's what we're trying to really work on. We see, you know, we're here to help you. Can't if you don't know what's going on.
Can I also add to this? Can people hear me? Wave if you can hear me.
Made a great comment about like everybody is that for you together. No. And I'm like, you know, I'm not the political side of her, and public health side of Samaritan. So I really can't speak to, but I do know that through our work through Samaritan, that the STARS program has really taken a step and looked at gender identity, gender specific services, and really have get outreach and continue to do outreach to ensure that the LGBTQ plus community is served and provided peer support specialists that identify and really looking and recruiting in that area as well as other organizations looking at working with learning and benefits. So it's a priority. And so that's as far as all the detail I do. That's all. Thank you.
No question. We have time for one more question. Oh, Isabel, would you like to make a comment?
I would. Thank you for recognizing that I had my hand raised. I'm sorry that I couldn't be in person with the rest of you, but I just want to say, Georgia, thank you for your question. This is a wonderful question. And I do think this is an opportunity where we have an area in which we have a lot of opportunity for growth. Our harm reduction program is funded by a grant that ends at the end of 2022. But part of that grant has been to engage our providers in harm reduction practices, and this includes equity and diversity for our LGBTQ community, sorry. And so this is an opportunity where I think we've had this work be increasingly challenging during COVID, and we have had limited opportunities to engage our providers about how to address this community in healthcare settings and clinical settings specifically. And when we have intersectionality with LGBTQ individuals and people who identify as trans and non-binary who are also dealing with substance use. We really need to be able to have our providers understand how to work with this community in clinical settings. And I think that this is an area where there is lots of opportunity for continued growth for us to work together to create like a resource list of providers in our county, but also around the state who are providing unique services in safe and affirming ways for people in this community and for what their particular needs are, and services that address the different intersectionalities that people have, whether that's needing for substance use and overdose work, also with someone who speaks a different language, also with someone who provides gender accessible care, gender affirming care. All of these things need to be talked about, and we need to work to kind of form bridges between the different systems that are available for treatment in our state. So thank you so much for your question, and thank you for letting me pipe in on the answer.
Thanks, Isabel. We have one more question here. Yeah.
I don't need a microphone. So this is kind of a two-pronged question. As I see it, one of the things that we have to look at is the fact that we've got to reduce demand and supply. And so on the demand side, I look at our kids, and what I see is a school district trying to swim upstream, and then the kids are cut loose for 3 months, and they don't have counselors available. They don't have those, for lack of a better word, safe people to go talk to. How do we get together and fill that gap for our kids during that time? And how do we increase resources for our schools to be able to, I'll be blunt, get this Russian roulette about fentanyl out there to these kids so they understand that this is not what I grew up with. This is what you're growing up with. And it's a whole different ballgame. And then secondly, on the other side of that, we need more comment teams, and we need the Lint team back, if no other reason than to stop that flow of those pills that are coming in to our community and getting ahead of that. But as we all know, that takes money. And so how do we come together to make a, for lack of a better word, an impassioned plea, a successful lobbying effort to get those dollars where they're needed, which is here in our communities? And I would take any suggestions you have.
Okay, I'll try. There we go. I can answer it for reconnections as far as, trying to help our youth. We've actually been in talks with the school district about coming in and, working with the kids. We have an adolescent specific counselor, Chloe, who's amazing with the kiddos. She's just great, and she's just really that person who, she's young enough to meet them on their level, and she looks like a child. She's so little. She's really relatable. Like they don't see her as a grown up. They don't see her as somebody above them. They really see her as, as their equal and somebody they can trust and somebody who's been through something they've been through. So we're working on community more with the school district and hoping to build some of those services.
Thank you.
Absolutely.
I know through Lincoln County Behavioral Health, we supply the therapists that go into the school. And I know in the summer they will continue to see children, and we're going to be opening a clinic in Waldport. They'll have mental health services in that area. Right now, as in every field, staff is what is really, fun. You can have funds, but if you don't have the people, then, and housing is an issue not only for the homeless, but for people that want to move here and work. And so I wish I could tell you the answer. I know we really want to help that population because so many kids get started from their parents. And so that's kind of what they grow up seeing, and that's just what I'm going to do. And they don't feel like they have any other choices. So I know we're trying, and I think we have a really good children's program at the behavioral health. And I think that they should at all schools have some kind of not just summer school, but activities. There's nothing for kids to really do. They get in trouble. And I've had people ask me for Narcan that weren't using, but at the skate park, and other places they want to have it in case they see something. And I think that's awesome. So
to address a little bit. I agree we need more funding for these things because I didn't mention in my presentation, but the position we moved to the drug team was the comment position. A number of reasons, we as a leadership team went through and discussed what's going to have the largest impact on what we're doing. It was difficult because we know comment is really addressing that harm reduction and getting people that are hurting themselves in the treatment. But we also know that the drug team, especially when we have two of the cities that are on board supplying physicians, are the ones getting that supply. We also know that comment, working with Director Mara, HHS, we think there's other opportunities with funding to get comment going again. I know we've had discussions about that. We just need to get our staffing where we can, heads above water so we can do it, but there are opportunities there to make that happen in our county.
Judge Walker. And then
when we talk about going into the schools, one of the aftermath of Measure 110 is we need to change the messaging about substances, because what the message, and I'm hearing it repeatedly every day in court, is that drugs are legal. And people enacted Measure 110, I know we're very adamant that wasn't what happened. That is the perception of your youth, is that drugs are legal. There is no consequence. So we really need to rethink, as a result of Measure 110, the messaging that we're giving in schools regarding substances, because that's what they tell me when they come to court. And it's hard to argue with them when it's $100 or $45 fine for your meth and your heroin, and it's a $265 fine, and you lose your driving privileges for possession of cannabis. So you have to change your messaging in the schools. And when you talk about prevention, it can't be what we used to do. And you can argue about the criminalization of drugs, but what it did is it did send a message of how, as a community, we thought about drugs. Is that they were bad and they were destructive, and there was a consequence if you were in possession of them. There is literally no consequence if you are in possession of them, and that's the landscape that we have to operate in. And so when we talk about going into the schools, it has to be a completely different message than what we were used to sending. And harm reduction has to be part of it. It cannot be all of it. And, people like come to court, I can tell them the ills of it, and it can kill you. They're in their addiction. They're not making rational choices, and it falls on deaf ears. And I'm really concerned. I disagree with the statement that the results and the numbers that we're seeing are the result of COVID. There is an absolute link between our numbers here in Oregon and Measure 110. And we have to accept that, and that's what we have to work with. But it has to start in schools with a completely different message. And I don't have the answer, but I'm hoping this group, that's what we focus on. And I'm happy to work with you folks, because that's what I'm hearing in court. I had a case last week, I never heard this before, been doing this for a long time, where a 45-year-old meth addict uses every day, brought his 14-year-old daughter and his parents in, and tried to convince me that his drug use was of no consequence because he was able to maintain a job and really was none of my business. I've never heard that before, but that's what ballot Measure 110 is presenting to us, because the message that he and his family got was it was none of our business anymore. And if you want to continue to use methamphetamine, why should we care? He'll pay the $100. One more.
So I think that, well, I know that the opposite of addiction is connection, and one of the things that the tribe does really well is they go into the schools, all the different programs go into the schools when they're really little, and it's all about forming those relationships that last a lifetime, that actually over multiple lifespans, because it starts with one generation and goes into the next. And those services don't stop just because we're on summer break or we're on break. As a matter of fact, they speed up. There's more of them. We rap with the kids, we kayak with the kids, we have growth courses, we do meal programs that are separate from the school but targeted at that age group.
they come alongside and do all the programming. They're truly integrated in everything that is happening, and it is about connection. That makes the difference. That seems to be the crux. And what we're talking about here is those relationships, authentic relationships where people really take in and, they work with them when they're tidies, when they're doing work experience. It's 100% a part of the community. So I think that there's lessons to be learned there.
Thank you very much. Well, this brings to a close our session with the panel here. Can we give them another round of applause? If there are board questions, I invite you to seek each of them out after the symposium today. So now we want to shift the conversation to what the rest of you are doing. So we want to be able to develop a comprehensive picture of all of the types of programs and services and resources that are available in the county that you all are doing. What I want to ask of you is to pull out this blue piece of paper I put on the table for you. I'm going to ask you to spend a couple of minutes writing down the kinds of programs, services, resources, or other activities you or your organization are involved in related to overdoses. This could be policy work, education. There could be any variety of things you're doing. I'd love for you to add that here. I will in a few minutes invite people to share orally, but I really want to make sure that we capture this on paper because we're going to put this list together after this.
That make a difference? That make a difference?
As you're writing things down, you don't have to put paragraphs, you put bullet points, a few words that describe the work that you're doing. That's this way. As you're working on that, also remember to put your name and organization on the top of the paper. We want to make sure to be able to attribute you or your organization to the work you're doing. I can hear people talking, I'm guessing that means you're finishing it up. If others are still working, that's fine. Keep going, write all those great things down. But I'll shift now to inviting people to share. So is there anyone who would like to share with the group about the work that you or your organization is doing? If you want to raise your hand, the microphone will come your way. I know nobody wants to be the first one to do it, but I'm sure somebody wants to brag about the great work you're doing.
All right, we have our first person. The Parole and Probation Department, I supervise the treatment court caseloads, and so forth. Supervision, drug treatment referrals. We have Narcan, we only have the tax with the 2 interim. I've had to use more than that. UAs, we have the juvenile probation officer who is dedicated to this place. Thank you. So I'll read a list and then I'll have you guys add in, because there's a lot of us here. There's 7 of us here. So, and we're all working on different papers, so if anything to add to it, read the ones that maybe we'll just go to it. So harm reduction, treatment, education, and referral to community partner agencies, intensive outpatient treatment and outpatient treatment, supporting housing, navigation services to resources, collaborating with medical providers in the emergency department for intervention services and program referral and enrollment, also in the discharge planners in the ICU, naloxone distribution for our community, homeless outreach support, pregnancy support for STDs, and outreach within the community. I don't hand it to me. I'll make a joke. Peer support. Oh. We have available peer support and counselors almost honestly 24/7. That's something that the connection says. We're always available day or night. There's a crisis, we show up. I don't know how many times we showed up at 12 a.m. Talking to somebody out of something and bringing them coffee and talking to my clinical supervisor. So, yeah. Thank you, Rita and Christine.
So my name is Megan. I work for Lincoln County Circuit Court, and I am the treatment court coordinator. We have 4 treatment courts in Lincoln County. 2 of them are drug specific. We also have a mental health court, and we also have a family treatment court, which is for families with DHS cases. So we have these 4 amazing programs in our court, and we work with a bunch of community partners that are here in the room right now.
Thank you very much. My name is Lacey. I'm the registered nurse that works for the MAP program, the Confederated Tribes of Select. We do everything from counseling, education, Narcan. We work with the local area schools, community outreach. We help navigate criminality. I work directly with the probation and parole officers. I administer all the MAC therapy medication. We offer family support, financial support, peer support. We're RAC services, so we can offer all of that under one roof. So I'm able to refer all of my clients right in the building. And most of the time when they get there, we can start day one.
Thanks for that. I asked you before you had the like, can you tell us about that? That's an accident that popped up a few times on the bingo card here today.
It's medication assisted therapy.
Yep. Medication assisted therapy.
To help you get off of opioids. So it's a prescription that sits on the same receptors. So it helps with the transition of either getting off of opioids, heroin, fentanyl. Sometimes people take it for life and sometimes people take it for a few years. So it replaces that need.
Excellent. Thank you for helping us understand that.
I just wanted to add that along with the wonderful services, wraparound services, integrated services that the Tribe offers, which are amazing. I think that one of the main important things, and one of the important things that all the services that we offer is our ability to partner and work regionally, and that is really a huge difference, hopefully for everyone. So that we should be respectful of that.
Thank you very much. We were. Who else would like to share?
So again, hi, I'm Georgia with Project Bravery, and that's with OWALA in Toledo. So we've been working with a prevention grant that's specific for tobacco and alcohol prevention with youth. So we started a whole summer program where any youth that's LGBTQIA2 spirit identifying can join us for activities through local artists. We meet at the cultural center, the library, other safe spaces. Within that, we've been able to reach out to the community and really teach the kids about
what it's like to know safe spaces in the community, safe people, different programs, and getting ready to go into the school. So a lot of prevention.
Thanks, Linda. Who else would like to share? Okay. Thank you. For those of you who don't know me, I'm Lady Danforth. I'm the district attorney. I just had a couple of thoughts real quick to share. So I agree with what Judge Blockford said in terms of Measure 110. It has caused a lot of problems. It contributes to the problem. It's made it virtually impossible for us to get addicts into the criminal justice system. It's increased the amount of drugs that are being delivered, and these aren't necessarily drugs that are coming from within Lincoln County. Dealers are in the valley, so even when we are able to find out who the dealer is, we don't prosecute it typically because they're not here. So that's presented a lot of challenges for us. But the one thing I did want to mention and just throw out there is prescribing Suboxone to people who have substance abuse disorder. For those of you who don't know, it's very common for people to trade Suboxone for dope. And so while the intent behind doing it is good, it also contributes. It can contribute to the problem and encourages more drug use. And so there's alternatives like Vivitrol. I don't know if there's anything else, but it's a shot that is administered, lasts for about 30 days. But then you know that they're not going to walk out the door and trade their Suboxone for dope. And so there's little things like that that I think as a community we can do to start to have a positive impact. So I just wanted to throw that out there. And then last thing, for those of you who don't know, I'm in charge of all unattended deaths in the county. So when we have an overdose death and somebody dies outside of the hospital, that's where I come in. That's where Abby Dorsey, who's a deputy medical examiner, comes in. And so we respond to those incidents and investigate them. So one of the things Abby's working on is developing sort of a best practice guide for law enforcement when they respond to these situations to investigate and see if we can figure out where the drugs are coming from. We've had numerous fentanyl overdoses, actually. We had one last week even. And we can't confirm it without talks, but we go to these scenes and we see those blue, fake oxys, dirty 30s on a piece of tinfoil, and the person's dead. And so we're trying to work with law enforcement to say, okay, let's look at the person's phone and where are we going to go next? And so our goal is to sort of treat every overdose death the same and make sure that we're investigating it as much as we can. And hopefully we will be able to get at least some dealers off the street. Thank you. Here.
I just wanted to respond about the Vivitrol and the Suboxone. Vivitrol is a really good medication. It's naloxone. It blocks the receptor so that if you use, you have to go into precipitated withdrawal. The problem is you have to be off of any kind of opiate for a certain amount of time. So most patients don't make that. I know when I worked in Massachusetts, anyone getting ready to get out of treatment, they would give them an injection of Vivitrol because that would give them 30 days to get hooked up with some other program. We monitor patients because we know that, they're going to slip up or sell. They may not have money. I could get some money by doing this. We do urine drug screens. We look for buprenorphine. If they don't have it, we make them come in more. We don't give large amounts of medication. We'll tighten those services or even tell them they need to go to a higher level. I think it works better if you can get them, even like if they're in jail, give them that shot and then they have 30 days. And unfortunately, that's the biggest drawback is the amount of time you have to be without. And, a lot of people like methadone. We don't have any methadone clinics, and really I feel like it's a horrible drug, but it is an option for people. But there is a lot of drug dealing there too. Just go to one of the clinics. Anyway, that's just what I wanted to say. It is a good, there is a Sublocade is an injection. Unfortunately, right now, we don't do that. It's a big procedure, but I'm hoping if we can get a full-time prescriber that does only that, we can do that. Because it has to be refrigerated. There's a certain way you have to give it, blah, blah, blah. But a lot of patients like it, then you don't have to worry about taking. It's kind of like with mental health meds, you know, the long-term injectables are really good. So.
Thank you. I just want to piggyback off that again. I do Sublocade. I think one of the biggest barriers that we're facing right now is, like Sheriff Lander said, we can only have 8 MAT patients right now in county. So that's to one nurse, I believe. Emily's the only one that I'm working with right now. And so we can't provide any more MAT therapy because she's at capacity. So for us to be able to catch them while they're incarcerated right now is very difficult. And to catch them when they get out is even more difficult. So I think that's one of the biggest barriers that we're facing as a MAT provider, is being able to get them when they are incarcerated. I work with them directly and they're sending kites daily and they can't get the medications they're requesting. When they get out, they can get the drugs that they're requesting. Thank you for having that. Does anyone else would like to share some work you're involved in? Yes.
Hi, everybody. I'm Ashley from Phoenix Wellness Center. I have Nicole with me, who's one of our peer mentors, and Danielle, who's the program administrator. So a couple things we do. We're an alcohol and drug outpatient treatment facility in Newport. We do serve all of Lincoln County. A couple things that we do. So we don't have a prescriber on staff that does the medication for MAT services, but we do work closely with several partners. So we actually provide the A&D component, the treatment component to MAT services. We do partner to do some Hep C HIV testing on site. Some of our mentors have actually been hosting several Narcan events, education, awareness, and distribution. We actually have one in 2 weeks. 2 weeks on Saturday the 23rd, if anybody's able to make it. We also do some support of employment with individuals, so building resumes, job interviewing skills, just general skill building are some of the services we offer there. We also have a specialized focus with youth. So we do alcohol and drug treatment with youth, have a youth group, and hopefully within the next couple of months, we'll have a full-time staff that just works with schools that will hopefully be in the schools when they're there, but we'll offer after-school services as well. And I know Jen is going to be talking about it later, the Measure 110 burn funding, but we're actually currently an Access to Care recipient. So because of the burn, because of Measure 110, we've actually been able to receive funding to provide these services to the community.
Thank you. I've heard the word burn a few times here today. That is the acronym that's on the back of your agenda. It's the Behavioral Health Resources Network. Hello, my name is Amber Martin. I'm with my sister's place, also known as my safe place. We are definitely at the cross section of so many things that we've talked about today. Although obviously mental health and addiction are just part of our whole picture that we're looking through, because that makes the most such a target to be further pressed. We know that the root cause of domestic violence is oppression, power, and control. There's a whole wheel on it you should look at. One thing that we try to do is look at the whole person. Many other people have talked about today. And so in that part of our process of our intake with our shelter or safe housing, or even just unpacking when someone comes to our door, like today I was late to this meeting because I came to the office and there was someone in the car. We need to sit down and unpack the whole picture. And that's part of addressing trauma, right? As it comes. And we're so grateful to so many partners who are in this room, because while we can't in-house offer all of these things, we have great relationships. And whether it's a referral, I was talking to my colleague here, 50, and we refer to everyone who spoke or mentioned something today. And on top of that, we're lucky to have many of those relationships that, in addition to referring, we do our handouts, or we take people, go right alongside them, or we've even had many of the providers that are in this room come right into our office or into our shelter. Pre-COVID, we did legal exchange. Our shelter was sober before. We have in the last few years changed that to be a low barrier shelter, so you don't have to be clean and sober to be within our doors. We recognize that it's more important to meet someone where they're at, and that sometimes the coping mechanism is we need to do drugs or we go down around once a week directions. I just really grateful for all the relationships that we have in this room, and always looking for partners, but it is back to that same thing that also everyone's talked about, capacity. But as it stands, we do try to do as much as we can to provide the whole picture. The nice thing about what we do is many of these services are part of the harder systems, where we don't have to, we get to be the soft place in the hard system. So it's not a requirement to totally be on drugs or totally be away from X, Y, and Z. And so oftentimes we get to hear the honest picture of what's happening, and then we get to help them make a roadmap. I will explain to people that I work with that we're like a GPS system. You plug in where you want to go, and we're going to help you recalculate until we get there. If you have to recalculate where you want to go, that's okay. But it's about the journey, it's about the whole person, and trying to meet those needs. Thank you very much. You had to be the furthest one. I know. You're welcome.
Hello, my name is Callie with the County Public Health, and we're in a really exciting time in expansion. We're about to hire a second harm reduction worker. Well, actually, we'll have two positions, but we're adding to our harm reduction team with a second person. And we provide legal issue services throughout the county with fixed site location, as well as meeting people where they're at. If they give us a call, we'll gladly go meet them. In addition, we partner with lots of folks like Phoenix Wellness Center, Reconnections, we make referrals to those places. We've also partnered with the Newport Library to offer needle exchange on site there, as well as naloxone distribution. So folks can come in and either exchange their needles, get naloxone, whatever their needs may be. I think that's what I have on. Just to add on to what Kelly was talking about, Lincoln County Public Health is doing a lot of really phenomenal things right now with substance use prevention. And one of those things that I worked on for many, many years, but was unable to do, and someone new in my old position was able to do it, was they started delivering a curriculum in the high schools called Boston Life Skills Development, and it is one of the best practice programs to teach kids refusal skills, and it has really great outcomes as far as keeping kids away from substance use from starting, and that's just phenomenal. I'm really excited about that. It was a pilot project at the Taft High School in Lincoln City this past year, and it was successful, and the school district has decided that they're going to get that in all of their high schools. And so I'm very happy to hear that. Another thing that public health has also partnered with me on is we did do a campaign for the school district to target kids to teach them about the dangers of fentanyl. This one pill could be your last. And it was an awesome experience. The school district partners with public health on a lot of things. And they developed really great relationships because of COVID, and that allowed us to kind of slip in the back and start talking about things like fentanyl. And I learned that each kid in Lincoln County School District, I think a certain age and higher, gets their own personal device, like a laptop computer that they do their schooling on. Well, the school district can push out messages to all of those computers. And so that's what they did for us, to get our campaign out to all of those kids. There's also a Remind app that a lot of parents have for Lincoln County School Districts. And it pushed out parental level information about fentanyl and the dangers to all of the parents as well. So a lot of great things are coming out of Lincoln County Public Health. We just don't have a lot of representation from the health promotion specialists themselves today, but there are phenomenal things happening. Thank you very much. Is there anyone else who would like to share their hasn't yet?
Well, maybe can we give folks a round of applause for the hard work they're doing? Okay, now I'd like to shift to thinking about a few other things. You have a salmon-colored piece of paper on your table. What I'd like you to do is think a little bit about what you're not doing that you wish you could be. So you have one prompt on there asking you about that. And also, what are the resources you're missing right now to be able to do that great work? The second item on that sheet there is what additional programs, services, or resources are needed generally in Lincoln County that don't exist that you think need to. So just spend a few minutes here writing down those answers. This is going to be a written exercise only, but I'm going to take these answers and put them into that list that I shared with you earlier that I'm going to work on after this symposium. Sorry to interrupt, but did anybody like a pair of glasses? We have a beautiful pair of glasses over here. I don't know. We were? Oh my God.
Dusty, are we gonna have? Jennifer's back.
We're running ahead.
For our audience members online, probably a little confusing. They are online.
So,
As you continue thinking about gaps and challenges you're facing, please do continue to write down your responses on a salmon piece of paper. I will collect them from the tables at the end of our session here today, so you can continue working on them. So next, we are going to have Jennifer Beckner again up here to talk with us about some plans for the future, including the Behavioral Health Resource Network, or BERN.
Okay, I think I'm gonna take my glasses off. I'm having a hard time with it. Steaming with the mask. So we've heard a lot of talk today about Measure 110, and there are a lot of negative impacts that we're seeing in our community, but I'm hoping that that's going to change soon. I'm here to talk to you today about what's commonly referred to as the BERN, Behavioral Health Resource Networks. This is the vision of Oregon Health Authority and the legislature to build a comprehensive system of care around addiction services in Oregon. And I'll just get started telling you about. So as you all know, in November of 2020, voters passed Measure 110. And they had hoped that it had two different goals for people using drugs, and they wanted to reduce the negative impacts and criminal penalties and to improve access to services. And they also wanted to improve outcomes for marginalized populations that are affected most by the war on drugs. The goal was to create a health-based, equitable, effective substance use and overdose prevention system, emphasizing caring and cost effectiveness over punishment and criminalization. This is the first of its kind in the nation, and I feel like all eyes are on Oregon right now to see how successful or unsuccessful this might be. Yeah. So how Measure 110 works. So it's Measure 110 decriminalized possession of small amounts of drugs as of February of 2021. And the idea was, instead of arrests and criminal records, now people are who possess a small amount of drugs, they're cited. And as Judge Bockhart explained, they get very minimal fines for this. The idea is that in order to waive those fines, someone who received a citation could call a 1-800 number. Right now, OHA is contracted with Lines for Life to provide 24/7 referral services. And when somebody calls in, they can be referred to the Behavioral Health Resource Network in their community. Behavioral health resource networks are being established in all 36 counties in Oregon and the 9 federally recognized tribes in Oregon. So in order to roll this money out, they created what's called the Oversight and Accountability Council. And this council is composed of people with lived experience, including people who are actively using drugs, as well as addiction and service delivery experts.
They came together as a council, and they worked with Oregon Health Authority to decide how these funds are going to be distributed. So the Oregon Accountability Council, the OAC, has dedicated approximately $270 million for the 21-23 biennium to fund these burns. They were really late in getting the funding out. I submitted our application for Lincoln County in December, thinking that we would have a decision made, maybe late January. We still do not have our funding in Lincoln County and are currently working on our contracts. The OAC determined that they would take 4% of the total of the $270 million and have the federal set aside for tribes. The idea behind the burns is that they're going to increase access to community care in the following areas. There has to be some kind of low barrier substance use disorder treatment, peer support and recovery, transitional and supportive housing, harm reduction, and incentives and supports to expand the behavioral health workforce. So the way they decided how much funding was available for each county in Oregon was based on this formula that they came up with, which didn't really make a lot of sense at the time. They looked at our Medicaid population, and one of the stipulations for burn funding is that people on OHP cannot use burn services, so I'm not really sure where that thought process came from as far as the Medicaid population. They also weighted it 30% on how many are on our homeless count, 20% on current arrests, and 20% on drug overdose deaths in the counties. So Lincoln County's total allocation from Measure 110 is $4 million or $4.6 million approximately. And because of the length, we're really not going to have a full 24 months to spend this money. But how they rolled it out was a competitive bid, and we all had to write proposals to submit to the state to tell them what we wanted to do to create our burn. This is the idea behind the timeline and where they're hoping that we'll get. They're really hopeful that we'll have the funding in hand by October. I think they're very optimistic that that's going to happen. I'm not even cautiously optimistic that that's going to happen, so we'll see what happens. But Measure 110 requires that a burn is only complete when it has 7 required components. And it's what we just talked about, the screening and behavioral health assessment needs, the individual intervention planning, case management, and connection to services, low barrier substance use disorder treatment, peer support, housing, harm reduction, and supportive employment. So when Lincoln County knew that this was coming, we got a collaborative group together. We reached out to all of our community partners who provided treatment, anything to do with mental health and substance use and addictions, and housing, and we all came to the table and submitted one collaborative proposal. This is a list of our collaborative partners that decided to apply with us, and so that was on behalf of Lincoln County HHS, Reconnections Counseling, Samaritan, the Confederated Tribes of the Select Indians, Coastal Phoenix Rising, Community Services Consortium, and a new player that's coming to Lincoln County, I'm going to tell you about in a minute, Faith, Hope, and Charity. So when the OAC came together to review our applications, there were 2 other applications that applied for services, or 3 in Lincoln County that were not a part of the collaborative. And so a lot of different partners were funded for different areas. And so for the screening and assessment, the individual intervention planning and low barrier SUD treatment, Bridges to Recovery, and that's our medicated assisted treatment program that Jamie Burris-Fish was talking about with our community health center. Samaritan Treatment and Recovery Program, that's the STARS program that Joanne talked about in Lebanon. That is our only residential treatment program in the entire. In the past, we've had to send people to Portland and Eastern Oregon, and they'd have to wait in line for hours in seedy parts of the neighborhoods and hope that they get a bed. But of course, because they are not from Multnomah County, they would often stand in line in vain and not end up with a spot. So STARS is one of our partners for treatment, and also Phoenix Wellness Center. Peer support and mentoring. So we have a great peer support group called Chance that's been providing services in Lincoln County for a few years that has partnered with us in the past, and so they will be contracted to do peer support services. And Faith, Hope, and Charity is a brand new organization to Lincoln County. It's a Black-led nonprofit agency located in Benton County that serves individuals throughout the Benton and Lynn County region that focuses on BIPOC and LGBTQIA Two-Spirit plus youth and adults who are recently released from the Oregon Department of Corrections and Oregon Youth Authority. Faith, Hope, and Charity works with local schools, juvenile departments, and parole and probation to offer services and supports to individuals who are identified as high risk. And that program is expanding here to Lincoln City. So we will have a peer support person from Faith, Hope, and Charity working directly with our Lincoln County burn. Phoenix Wellness Center is also being funded to do peer support and mentoring, and Samaritan Treatment and Recovery Services is going to have a peer support worker in the emergency department in our hospitals. So for housing, Lincoln County has a really horrible housing problem and not a lot of providers. So we partnered with Coastal Phoenix Rising, which is also known as Project Turnkey, and that's a facility up in Lincoln City. They have 38 available units. I think it's like an old hotel that they renovated into temporary supported housing for people. So with our application, we applied for funding to purchase 10 units that are master leased for burn clients for a contract period of 18 months. And so we're hoping that this will help with the problem that Jamie identified with when people are ready to start treatment, they really have to be surrounded in support services. If you have a couple that are using together and only one decides to do treatment, that's an issue. We talked about, the DA was talking about how she's concerned about Suboxone being diverted in the community. And we've seen in domestic violence situations that can happen, where one partner is taking the other partner's medication. And so these 10 beds or 10 units are really essential to the success of our program. The burn clients will be supported through contracted housing, and we were going to have an embedded peer support specialist hired through Reconnections Counseling with access to all associated recovery programs, peer support specialists, traditional health workers, and harm reduction workers. Reconnections is not funded to provide treatment through our burn, but Phoenix Wellness Center was. And so this is something that we might have to work out a partnership to see how we can fill that gap. For harm reduction, we asked for funding to support the Lincoln County Harm Reduction Program and the Confederated Tribes of the Siletz Indian Harm Reduction Program. So Ruby had mentioned that the county and the tribe both had a grant recently to work on HIV and Hep C elimination, and that grant is coming to an end, which would have eliminated some of our harm reduction work that was happening. And so with this funding, Lincoln County Health and Human Services is going to be able to expand our harm reduction our harm reduction program by adding another worker. So we'll be going from 2 full-time harm reduction workers from 1 to 2, and also have a dedicated RN that can go out into the community with our harm reduction workers to do things like STD treatment and testing, vaccinations. I'm hoping that in the future we can work out a way to maybe help deliver medicated assisted treatment medications to people who are already on our program to help with the transportation issues that are going on. We've also included money in our budget to pay for things like cab vouchers for transportation, incentives for clients to engage and complete treatment. The tribe is going to have continued funding for their harm reduction one of their harm reduction worker positions. And Phoenix Wellness Center was also awarded funding to do harm reduction. We kind of already touched on this, so I'm going to just quickly go over it, but basically it works to meet, harm reduction works to meet people where they are and to reduce the negative effects of drug use and sexual behaviors. These are all things that are harm reduction programs with the tribe and Lincoln County Public Health do all of these services are offered free of charge. So they can come in and get rapid HIV testing, rapid hepatitis C testing, syringe exchange, condoms and first aid supplies, naloxone distribution and education. I know that our program also tries to have things on hand like snacks. You know, we have a lot of people that show up for syringe exchange and they're hungry. And we also provide things like those little hand things that make your hands warm in the wintertime when you're freezing, you know, little pocket things, clean socks, new clean socks, just things that people, basic needs for people. The supported employment part of our grant, our partner is Community Services Consortium, and what they're going to offer is they're going to do supported employment services. They have a really cool program that they have that does paid work experience with different community partners throughout the county. So they have contracts with like DHS, the Department of Human Services. I know that they've had contracts in the past with Lincoln County, and they work on barriers to employment, help them get ID so that they can apply for jobs, make sure that they have the appropriate clothing for interviews, and help them with resume building. And they also help them with things like transportation to get to those interviews and appointments. Phoenix Wellness Center was also awarded funding to do supported employment. So I'm really excited about this. It's been a long time in coming, but the idea behind this is that anyone in the community who knows someone who needs treatment can call this 24/7 hotline and be referred to the local burn. And our goal as a collaborative is to have no wrong door. So if anybody walks into any of these agencies and is in need of treatment or has a substance use disorder, they're going to be able to access this burn and refer a resource network through any one of our agencies and get the services that they need. It's a lot of money, and historically, treatment and mental health in general have always been underfunded in Oregon. This is funded with not only it's funded with cannabis tax revenue. And so I'm not really sure what it's going to turn out to look like in the future. Because in Lincoln County, we use a lot of our cannabis tax revenue for prevention programs with kids. And we also did that in Lynn and Benton counties. And with that revenue gone, it now goes to support the burns. And I'm hoping that in the future and the next cycle of grants that come out for behavioral health resource networks, we can include something for kids and prevention programs for you, because I think that really was one glaring missing area in this whole process. So where we are right now, we are working with the Oregon Health Authority on contracting, and once that's all in place and we figure out how this is going to look for Lincoln County, we'll be working on a referral process so that any of you can call any of us and get the services that you need. One thing that was funded for Lincoln County is our OVAP program, Office-Based Addiction Treatment Program, Registered Recovery. And what Jamie was talking about is we are hoping to add one dedicated prescriber to that program. Because right now we do have 2 waivered prescribers, but that's not their main job. They work in behavioral health, they work in primary care, and they see patients for a whole gamut of problems and issues that are happening in healthcare needs.
And so it's really difficult for us to get people into appointments same day. You know, I'm really hoping that with a dedicated position for a prescriber, that we can offer, you know, maybe odd hour appointment slots so that they're not, you know, just Monday through Friday, 8 to 5. And we know that a lot of people in the service industry can't make those appointments. So I'm very excited. I think that this could be astronomical as far as impacts in Lincoln County for people with substance use disorder. If you have any more questions about it, we're going to try and keep the public updated with media releases and information on our website as this is coming together. As I said before, we're just right in the contracting phase of this, but I do think that this will be up and operational, hopefully within the next 6 months. Our biggest barrier is going to be finding people to fill those positions, because we had a lot of positions that were created through this funding. Thank you.
Our next presenter is Ursula Marinelli. She is the Coastal Foundations Director, Pacific Communities Health District Foundation, and North Lincoln Hospital Foundation. She's going to tell us about Coastal Stars.
Good, thank you. So the wonderful thing about being last is that a lot of what is going to be on my slides, I just can go right over because it's already been covered. And the other thing is there were a couple of things that were talked about that I now can incorporate and feel like it will answer some questions. So this is the why. Of course, it's been talked about a lot today. What we are trying to do is build a substance use disorder residential and outpatient treatment center here in Lincoln County. And that is, you've heard it referred to as STARS, and so we call it the Coastal Stars. It will be run by Samaritan and similar to the program in Lebanon, and I'll talk a little bit more about that. I do want to say that this photograph here is a picture of Gina and her family. Gina's here. And Gina was kind enough to share her story with me very early on in this process so that we could use it in some of our materials. And I think it's a great example of Gina had to go to Corvallis for residential treatment, and her daughter Desi and her husband Todd both had to go to Baker City, so 300 miles away for residential treatment. So it is going to be a 16-bed substance use disorder residential and outpatient treatment facility for adults. I wish we could accommodate youth, but at this time we cannot. Joanne did talk a little bit about what STARS offers. It is not detox. It is substance use disorder treatment, individual therapy, medication assistance treatment, peer support, educational programs, those sorts of things. We, a lot of you in this room have had conversations with me as I've been learning about this program and learning about what this community needs. And so I have heard a lot of your stories, and I've been sharing those stories with the folks in Lebanon, as well as the people that are going to be creating the actual facility here. And it is, I can tell you, starting to inform some changes up in Lebanon too. And one of the things, Georgia, that I would like to let you know about is, the idea of gender-specific services and gender-specific rooms. One of the things that we are going to do with our facility from the very start is build it so that we can accommodate people who are non-binary, and so we have the luxury of being able to do that because we're starting sort of from scratch. Also, Ruby and Dee have heard from me. We're going on tours, and we've been talking a lot about what this program could look like, and we're just going to keep talking to people in the community to make sure we're able to really meet the needs of the community. We are thinking approximately 200 inpatients per year, 600 outpatients per year, but of course that is dependent on a lot of things. So the where and how. So the photograph that you see is a facility that the Pacific Communities Health District Foundation, Pacific Communities Health District purchased in March. And that is over on Northwest Phoenix, which is just north of Newport. It was an adult foster care home, and so it is set up for residential living. And that is going to be the start of the facility that we build. For those of you who may not be aware of what the Pacific Communities Health District is, it's a taxing authority, 5-member elected board. If you own property and you are from the middle of Lincoln Beach all the way along the coast down through yachts, a portion of your property tax goes to the Pacific Communities Health District. And they are tasked with making sure that we have a hospital in this community as well as other healthcare services. So the health district owns the hospital. They own this building that we're in. They own, any of the buildings that Samaritan operates, they own. So they are going to own, they do own this facility, and they are going to own the substance use residential treatment facility once it is complete. And the beauty of that, and Samaritan is going to operate it. Samaritan operates the facility in Lebanon, and much of the same staff is going to help to create the program here. That's Lamont Morgan, as I mentioned, is the operations director. And but I will just say that the beauty of having the health district own the facility, if for ever, out of any reason down the road, Samaritan cannot operate it, something happens and they're not able to do it, the health district owns the facility and they'll make sure that somebody else is operating it. It's just like the dialysis center. When we opened the dialysis center, the Samaritan ran it for about a year. There were reasons why they could no longer run it, and the district was able to find another partner to run it. So it's that same model. It's a great model. The foundations, North Lincoln Hospital Foundation, Pacific Communities Health District Foundation, we are tasked with raising about $6 million to remodel the current facility and create a 6,000 square foot addition. That's going to house a commercial kitchen, group spaces, offices, exam room, things like that. And so, yeah, so that's the partnership, which means that we are looking to the community really to help us create the facility. Samaritan is a nonprofit organization, which means we don't turn anyone away for inability to pay or insurance cut. And that is why they are Samaritan. I'm a Samaritan employee, so that's why Samaritan is asking the community, the foundations, to raise money to actually build the facility, and then they are committed to operating it. All right, this is what the timeline looks like, assuming that we have the funding. So the building's already been purchased by the district. We have selected Clark Jones Architects as our architects. So the design work is going to get started very quickly. And they are going to have visioning sessions. They're going to have one-on-one conversations with some of our partners. So we're going to be reaching out to people with lived experience. Some of the communities that we talked about. We'll be talking to people at the Bravery Center, Georgia, on picture information. The other thing about Clark Jones, which was new to us, those of us who are on the panel, and selected them, is they have a researcher who talked about harm reduction design. And I don't know if anybody else has heard about harm reduction design in architecture, but they were the only ones who talked about it, who we met with, and that was one of the reasons that we chose that. So that's going to be built in. We are going to issue an RFP for the general contractor by the end of the summer. Hopefully have somebody on board by October, and then break ground in the spring and start seeing patients in 2024, first quarter of 2024. Again, this is all dependent on our funding. So our financial partners today committed. We have the City of Toledo, City of Walport. There are several corporations and individuals who have contributed to the project. And then Lincoln County Commissioners just approved a $500,000 allocation from the American Rescue Plan Act funds, which is a huge boost to this fundraising effort. Those things that we have pending or planned are with City of Newport. We have a meeting set up with them in August to talk about some of their opioid settlement dollars being put to this project. We have a federal appropriations request out for $1 million with the senators, Wyden and Merkley. Of course, lots of other individuals and corporations. North Lincoln Health District is going to support it. We just don't know how much yet. And that is, even though it's in Newport, it is a county service. So it is not just for Newport, it's for the entire county. So we really are hoping that everyone in the county will be able to help us support this. And then the Oregon Health Authority, unfortunately, we, up until last week, were under the impression that there would be a substance use disorder facility related grant application released this month. And that was the plan. And then on July 1st, they announced that plan is on hold indefinitely. We really were hoping that a good deal of our funding for this facility was going to come through that program. And now that that is on hold indefinitely, although we're doing some advocacy, doing some advocacy, it is, it's not looking great. So anyway, if you have any questions, if you have ideas, if you want to give input, please contact us. This is the contact information. It's on the handout that I put on all of your tables. If you have questions, just please reach out to me. Thank you.
Right, well, we are reaching the end of our time here together. I think we have achieved our goals here today to understand the problem better and also understand more broadly what you all are doing towards reducing, preventing overdoses. So first I want to say thank you to all the presenters who presented here today. And I want to say thank you to all of you for your contributions, especially on those pieces of paper I asked you to write on, the blue and salmon colored ones. I'm going to take that and put that together in a comprehensive list to show the big picture of what's going on. I've also been asked to make sure to let you know there's still food over there. We hope you will take home. And if you really liked it, we want to say thank you to Scotia in Waldport for providing our food here today. So with that, I'd like to turn over to Commissioner Jacobson for closing remarks.
All right, well, it's been a really long day, and I also really believe on ending on time, so I will be brief. But first of all, to everyone that was involved in planning, whether you planned to order the food, showed up early to set tables, all of those people, please stand up so we can just give you a round of applause and thank you for putting this on. Also, in thinking about what is next for this group and our community, I really believe that relationships are often what helps us build collaboration and get out of problems. I love what Ruby said, which is I think partnership is the opposite, or connection is the opposite of addiction. We didn't do formal introductions in the beginning, and I think it's important that we do a version of that. So I'm going to read out some different sectors of people that I know are represented here today. And when I read your sector, I want you to stand up. If you fit in more than one, stand up for all of them that you fit in. What I want everyone else to do is look around the room as people are standing and find somebody you don't know. If you know everybody, gold star for you, awesome. If you don't know somebody, make a mental note of a person or two you don't know, and please, as we exit out the door today, go and find them and introduce yourself. I think the more connections we have in our community, the better collaboration we can build. So again, stand up when your sector is called. I'll give everyone a minute to look around and find someone you don't know. So healthcare, all of our healthcare people. If you fit in more than one, it's okay. All right. Okay, law enforcement and criminal justice. Including, of course, Judge Boxer, you can stand up, yeah. All right, local government, state government, tribal government, federal government.
Okay, thank you. Community-based organizations. All right, I think you guys know each other, that's good. All right, harm reduction. Same people standing back up again, okay? And if there's any other category not mentioned or you feel like you just didn't fit in anything. Okay. All right, so again, I hope everyone made a mental note of someone they don't know, and please go introduce yourself to that person. And as we kind of move forward here, let's please all stay in touch, and most importantly, let's stay together. As we go through this is a really tough issue, and I think the trends and statistics we were showed today were scary, frankly. But us all staying together and linking arms, I think, gives us the best chance we have in our community. So thank you for coming today. Thank you for everyone that put that on. And again, let's stay together as a community as we go through this. Thank you. Oops.